So today we are going to do some past paper questions, right? So we will be doing a few true false as well as some SBS. So I'm hoping to do about 10 true false and about 15 SBS in this 2 hours. So let's make this like a discussion. So just clear your doubts, right? I mean, if you're committing 2 hours to this, you have to make maximum use of it. So feel free to ask any questions in between. If you have any doubts, if anything is not clear, just unmute yourself and ask, and we can have a small discussion, right? So we'll start off. I'll share the screen. All right, so we'll start off with some true false, right? So so as you know, like your exam, it's going to have both true false as well as SBAs, right? So now true false are the tricky ones because you have negative marking. So I hope you know that. So if you get an answer correct, you're going to get a mark. But if you get an answer or a stem wrong, you're going to get a negative mark. So the negative marks are going to be carried only within the question. So it's not going to carry forward to your next question, right? So I think the most important thing when you are answering true false is to make sure that you don't answer too much as well. It's important that you answer the right number of steps. Because what happens is if you try to answer too many, you might get some wrong and you will go down. At the same time, if you don't answer enough, again, you will not score enough marks, right? So it's good if you can answer about 70 to 80% of the stems. So that way you can get enough marks. So what usually happens is when you keep answering, you start feeling a bit like, okay, I need to score more, I need to get a good rank. So you are tempted to answer more and more. But these questions are designed in a way that if you try to answer more than what you should, you'll end up getting lower marks. So make sure that you focus and mark the correct number of steps. So that's the most important thing. So about 70 to 80% should do. All right. So it's not that you have to answer all 5, right? So the best way to go about this is to, first of all, keep answering the ones that you're very, very sure about. So like the steps that you're very, very sure about. And then after you finish, count and see how much you have marked. So if you mark about more than 70%, that's fine. But if you mark less than that, then you need to answer a bit more. So that's how you should go about answering true or false. So if you're not sure, it's always better to leave it blank. All right. So, okay. So let's start with the first question. I hope you can see it. First question is features of a complete third nerve palsy are absent corneal reflex, constrictor pupils, divergent squint, lateral gaze palsy, and ptosis. So can you put up some answers?
So we can't see the question slide.
Oh, okay. Sorry.
Now we can see.
Can you see it now?
Yes.
Okay. So features of a complete third nerve palsy are absent corneal reflex, constrictor pupils, divergent squint, lateral gaze palsy, and ptosis. So any answers? All right, so I can see a few answers. So let's discuss about this, right? So now when you look at the nerves that are involved in the movements of the eye, there are mainly 3 nerves that we talk about, right? So we have the oculomotor nerve, that is your third. Then we have the abducen nerve, the sixth, as well as the fourth nerve, right? So the nerves 3, 4, and 6 are the nerves that are mainly involved in ocular movements. And each of these nerves, we supply specific muscles, right? So if you look at the muscles of ocular movement, right? So when you look at the muscles of ocular movement, there are mainly 6 muscles, right? So you have the medial rectus, the lateral rectus, the superior and inferior oblique, as well as the superior and the inferior rectus. So let me show you how these muscles work to move the eye, right? Give me 1 second. My presentation is done. Right. So you can see my screen, right?
Yes, sir.
All right. Yeah. Sorry about that. Okay. So now if you look at this diagram, which I put out, this shows how the muscles are involved in the ocular movement. Now these are your two eyes. So you can see the right and the left, right? So let me just get up a pointer. So this is your right eye and this is your left, right? So now each of your eyes have 6 muscles that help in the movement of the eyeball. So you have the medial rectus, which basically brings your eyes towards the nose. So when you sort of look at the tip of your nose, when your eyeballs sort of converge in, that is called adduction of the eyeball, that is controlled by your medial rectus. Then the muscles that move your eyeballs away from the nose, those are the lateral rectus. So the lateral rectus will cause something called abduction. All right. Then you also have two important muscles, the superior rectus, which helps in elevation of the eyeball, and then the inferior rectus, which helps in depression of the eyeball. Elevation of the eyeball is also aided by the inferior oblique muscle, as well as the depression is also helped by the superior oblique muscles. So these are the 6 main muscles, and these are the directions that the muscles would move your eyeball, right? Now it's important to know which of these muscles are innervated by which of the 3 nerves. So now you have mainly 3 nerves that control the movement of the eyeballs. Third, oculomotor. Fourth, trochlear. And the 6th, that is abducent. Now the easy way to remember which nerves are supplying which muscles is remember that the lateral rectus, which causes abduction, that is movement away from your nose, is controlled by your 6th or your abducent nerve. All right. The superior oblique, which causes depression of your eyeball as well as intorsion of your eyeball, is controlled by the trochlear, which is the 4th. So you just have to remember those two, that the lateral rectus causing abduction is controlled by the 6th. The superior oblique causing depression and internal rotation is controlled by the 4th or trochlear. Everything else, your superior rectus, your inferior oblique, your medial rectus, your inferior rectus, they are all controlled by your 3rd nerve. All right. So what is going to happen if you get a 3rd nerve palsy or an ocular motor nerve palsy? So when you get an ocular motor nerve palsy, is your superior rectus going to work? No, because it's supplied by your 3rd. Is your inferior oblique going to work? No, because it's supplied by your 3rd. Your medial rectus, again supplied by the 3rd. Your inferior rectus, again supplied by the 3rd. So the moment you have a 3rd nerve palsy or oculomotor nerve palsy, all these muscles will stop working, right? And the only muscle that's going to work is this superior oblique as well as the lateral rectus. So now what's going to happen is there's only movement in this direction, that is away from the nose, and in this direction, right? So what's going to happen to your eyeball is it's going to get deviated outwards and downwards. It's going to go down and out. So that's exactly what's going to happen when you have a paralysis of your 3rd nerve. Let's say you have paralysis of your 6th, then the eyeball is going to go medial. It's going to adduct because it's going to be the medial rectus that's going to function. So I hope you understood that this diagram is very important for you to know, because if you remember this diagram, you can easily figure out ophthalmoplegias or paralysis of eye movement. So all you need to know is this diagram, and you can just figure out what's going to happen when a cranial nerve is paralyzed. So when you have a complete 3rd nerve palsy, what's going to happen is your eyeball is going to get deviated downwards and outwards. But now the things about a 3rd nerve is the fact that in addition to the movement of the eyeball, it also has some other important functions. So one is it is important in the pupillary reflexes as well. So it helps in the constriction of pupils. So when you have a 3rd nerve palsy, the constriction of the pupil is affected, and as a result, you are going to have a dilated pupil as well. It is also important for the control of the opening of your eyelids. So the opening of the eyelids is also controlled by a third nerve palsy. So when you get when you get oculomotor nerve palsy, that's going to be ptosis. When we talk about the abductor nerve and the trochlear nerve, it's only going to be a problem in the muscle movement or the eyeball movement. But when it comes to the third nerve, in addition to the eyeball movement, remember there's a problem in your pupillary reflexes as well as there's going to be ptosis as well, right? So now when we go into the stems, features of complete third nerve palsy are absent corneal reflex. Now the corneal reflex has nothing to do with the third nerve, right? Corneal reflex, the afferent pathway or the sensory pathway is by your trigeminal nerve. So the ophthalmic division of the trigeminal nerve or your fifth cranial nerve will pick out the sensation. And the efferent pathway causing your eyes to shut is by your facial nerve. So your third nerve has nothing to do with the corneal reflex, but it has everything to do with your pupillary reflexes. So the corneal reflex being absent is false. Constrictor pupils. As I said, third nerve is important for the constriction of the pupils. So when you have a third nerve palsy, there's going to be a dilated pupil. So that is false as well. You're going to have a divergent squint. What do you mean by divergent squint is that your eyeballs are going outwards. Convergent squint means your eyeballs are coming inwards. Now, when we have a third nerve palsy, your eyeballs are deviated downwards and outwards. So that is basically a divergent squint. So that is again true. Then the D part is lateral gaze palsy. So lateral gaze palsy means you have difficulty moving your eyeball outwards. But when you have a third nerve palsy, you have difficulty moving your eyeball inwards. So you have a medial gaze palsy. Lateral gaze palsy you would get only in a abducent nerve palsy. So in a third nerve palsy, what you get is a medial gaze palsy. So that is false as well. Ptosis again true, because we are talking about the third nerve, where in addition to the movement of the eyeballs, it also has an action in the control of the eyelids as well. So those are the effects of the third nerve palsy, and I hope you understood that. So now let me explain what this complete third nerve and this incomplete third nerve, what does that mean? So previously we used to label third nerve palsies as medical third nerve palsies and surgical third nerve palsies. So medical third nerve palsies is basically when your pupillary reflexes are intact. So you don't have a dilated pupil. So you have a deviated eyeball downwards and outwards, but your pupils are normal. It's not dilated. And surgical third nerve palsy was when the pupil is affected or when the pupil was dilated. What a complete third nerve palsy means is again that the pupils are also affected. So there has to be a dilated pupil, which is why B is false. And a complete third nerve palsy would also mean that you have a complete ptosis. So what is a partial ptosis and what is a complete ptosis? Now ptosis is when your eyelid sort of droops down. If your eyelid droops down only just a little bit, but you can still see, that is called a partial ptosis. Complete ptosis is when your eyelid droops so low that you can't see because your pupils are getting covered by the eyelid. So when you have a complete third nerve palsy, you have a complete ptosis where you have the eyelid shutting down so much that you can't see. So that is the difference between a complete and incomplete third nerve palsy. So I hope that is clear. And if you have any doubts in the first question, please do let me know. All right. So if not, we can go on to the next one. All right. So the second question is, wasting and fasciculations of the tongue are both seen in pseudobulbar palsy, myasthenia gravis, motor neuron disease, nasopharyngeal carcinoma, and Paget's disease of the skull. So what are we talking about when we say wasting and fasciculation of the tongue? So here, what the concept that is being tested is bulbar palsy versus pseudobulbar palsy. So before we go there, there's a question, where can we see incomplete ptosis? So it is due to an incomplete injury to the third nerve. So when you have a complete paralysis of the third nerve, you get a complete ptosis, right? Fine. So, so regarding this one, So the concept that is being tested here is bulbar palsy versus pseudobulbar palsy. Now, when we talk about bulbar and pseudobulbar palsy, we are basically talking about the lower cranial nerves. Now, we have 12 cranial nerves, the lower ones, that is 9, 10, 11, 12. So when we have a problem in any of those, right, when we have a problem in any of those, we call it either a bulbar palsy or a pseudobulbar palsy. So what is the difference between these two? So the difference is one is sort of an upper motor neuron pathology and another is a lower motor neuron pathology. So I'm sure you are familiar with upper motor neuron and lower motor neuron pathologies when it comes to your limb examination. So when we have an upper motor neuron paralysis of the leg, we have spasticity, increased tone, increased reflexes, and upgoing planters. When we have a lower motor neuron paralysis of the limb, we have wasting, we have fasciculations, we have reduced tone and reduced reflexes. So when it comes to the lower cranial nerves, 9, 10, 11, and 12, again, we can have a upper motor neuron lesions, basically lesions occurring in the brain. For example, it can be due to a stroke, it can be due to a demyelinating lesion, it can be due to tumors of the brain. That can affect the cranial nerves 9, 10, 11, 12. Or it can be due to lesions lower down in the pathway. So it can be a lower motor neuron lesion of the cranial nerves. For example, it can be due to things like myasthenia gravis, skull-based tumors, infections, muscle and neuromuscular problems. So we can sort of localize what sort of pathology we are dealing with by differentiating whether this is a pseudobulbar or a bulbar palsy. So when we have a pseudobulbar palsy, just it is a upper motor neuron pathology. So just like in the limbs where we get increased reflexes, due to a pseudobulbar palsy, again you will see increased reflexes. So the gag reflex. So gag reflex is when you sort of irritate the pharynx, the patient gags, like coughs out. So that would be normal or increased in the case of a pseudobulbar palsy because it is an upper motor neuron lesion. But when it comes to a bulbar palsy, that reflex is going to be absent. So even if you irritate the patient's pharynx, they are not going to cough. Palatal movements are going to be absent in both because whether it is upper motor or whether it is lower motor, the movements of the muscles are going to be paralyzed. So there's going to be absent movement. Speech again helps to differentiate between the two. So when we talk about pseudobulbar palsy, we get sort of a spastic speech. We sometimes call it Donald Duck speech. So I think you're all familiar with Donald Duck, a famous cartoon character. So if the patient speaks sort of in that way with a very spastic sort of a speech, that is seen in pseudobulbar palsy. But when it comes to a bulbar palsy, since it's lower motor neuron, your muscles are going to be all sort of collapsed and they are not going to be opening up properly. So since your muscles are sort of collapsed and not opening up properly, you're going to get a flaccid paralysis of the muscles. And that is going to cause a nasal speech. So it's going to seem like you're speaking with a blocked nose. So if a patient with a if a patient with lower cranial nerve palsies are speaking with a sort of like a blocked nose or sort of like a heavy nose, think about a bulbar palsy. And another very important way to differentiate is by looking at the tongue. So when you talk about a pseudobulbar palsy, since it's upper motor neuron, you're going to get a very spastic tongue. So spastic tongue is the patient is unable to sort of move it. So when you ask the patient to protrude the tongue, he will not be able to protrude the tongue. The tongue will be sort of stuck inside his mouth. So if you ask the patient to put the tongue out and it's sort of stuck inside the mouth, think about pseudobulbar palsy. Well, when it comes to bulbar palsy, it's a lower cranial nerve pathology. So there's going to be a wasted flaccid tongue with fasciculation. So wasted flaccid tongue with fasciculations are seen in a bulbar palsy. So if we go back to our question, wasting and fasciculation of the tongue are both seen in. So in other words, if I rephrase this question, what are the causes of a bulbar palsy, right? Because wasting and fasciculation of the tongue are seen in the bulbar palsy. So what are the causes of bulbar palsy? So bulbar palsy is a lower cranial nerve pathology. So pseudobulbar palsy is false because it is an upper motor neuron pathology. Myasthenia gravis is a lower cranial. It's a lower motor neuron pathology because it's a problem with the neuromuscular junction. So when you have a problem in the neuromuscular junction, it's going to present as a lower motor neuron pathology with wasting and fasciculation. So that is going to be true. Motor neuron disease is a very interesting illness where it is a disease of the anterior horn cells. So motor neurons are sort of located at the exact junction between the upper motor neuron and the lower motor neuron. So these motor neuron pathologies will have some features of upper motor neuron lesions and some features of lower motor neuron lesions as well. So in a motor neuron disease also, we can get wasting and fasciculation. So that is again going to be true. Nasopharyngeal carcinoma is going to be a local tumor in the nasopharynx, which is going to locally destroy the muscles as well as the nerves. So again, that is going to be a lower motor neuron pathology, which is a bulbar palsy. So that is again true. Paget's disease of the skull is again a very important disease where there is sort of damage to the base of the skull. So as you know, these lower cranial nerves will exit the skull from the base of the skull. So when you have a pathology affecting the base of the skull, you're again going to get a lower cranial nerve palsy of these cranial nerves. All right, so you're going to get a low motor neuron sort of pathology of the cranial nerves. So Paget's disease of the skull is once again going to be a bulbar palsy. So if you take the answers for this, the first one is false, but the rest of them are true because all of the last four are low motor neuron pathologies which cause bulbar palsy. Yes, so there's a good question. Does myasthenia gravis has wasting? So yes, so myasthenia gravis is again a neuromuscular junction pathology, right? So since it's a neuromuscular junction pathology, if it's there over a long period of time, it can cause some amount of wasting. But as compared to pathologies like maybe a lower a neuronal pathology or a muscle pathology, the wasting is not marked when it comes to myasthenia gravis. So when it comes to myasthenia gravis, wasting is not a very predominant one, but long standing it can cause. All right. But myasthenia gravis, what you have to understand, is a well-recognized cause of a bulbar palsy. All right. So if there are any more questions, please, you can always unmute yourself and ask. All right. So let's go to the third one. So this is a fairly straightforward one. So regarding heart failure, arrhythmia is a cause. Edema, edema is due to salt and water retention. Elevated BMP helps in the diagnosis. NSAIDs worsen the condition. Furosemide improves survival. So any answers? All right. So heart failure. So if you talk about heart failure is when there's a structural or functional impairment of the heart so that the heart is unable to pump blood effectively to meet the demands of the body. So as you know, heart is the organ that basically pumps blood around to all the other organs in the body. So if the heart is unable to do that properly and the rest of your organs are not getting perfused, that is called heart failure. It can be due to various causes. It can be due to structural causes like cardiomyopathies. It can be due to ischemic heart disease. It can be due to infections such as myocarditis, viral or other pathogenic myocarditis. It can be due to endocrine pathologies. It can be due to arrhythmias. It can be due to hypertension. So you have a whole load of causes. Any cause that damages the heart can eventually lead to heart failure. So when you look at the first 10, arrhythmia is a cause. That is absolutely correct. So when you have arrhythmias for a long period of time, that can cause heart failure. A very good example is atrial fibrillation. So when you have atrial fibrillation, your atria are contracting so irregularly and so rapidly that your ventricles can't keep up with the atria. So there's incoordinated atrial activity with the ventricles sort of lagging behind. The end result is that your ventricles are unable to pump blood properly and the patient goes into heart failure. So most of the tachyarrhythmias like atrial fibrillation can cause heart failure. Edema is due to salt and water retention. So that is due to the activation of your RAS system. So the RAS system is for the renin-angiotensin aldosterone system. which is a very important system that you should be familiar with when it comes to heart failure. So this is the renin-angiotensin-aldosterone system. So what happens in heart failure is patient's heart is not pumping enough blood. So as a result, there's going to be hypoperfusion of the kidneys. So when there's hypoperfusion of the kidneys compensate by secreting renin, which then converts angiotensin organ to angiotensin 1, which gets converted by angiotensin converting enzyme to angiotensin 2. Now this angiotensin 2 is going to act on your renal tubules and it's going to cause retention of sodium and water. So this retention of sodium and water is going to cause edema or excessive accumulation of fluid within your body. And one of the hallmarks of the clinical features of heart failure is the accumulation of fluid. I mean, when you go to a heart failure patient, when you press on their shins, there's pitting edema, right? There's always fluid overload. When you auscultate the lungs, there's bibasal 5 cramps. That is again due to fluid overload. So fluid overload is one of the major features of heart failure, and that is due to salt and water retention. So that is correct. Elevated BMP helps in the diagnosis. Now, when you have fluid being accumulated in the body due to this renin-angiotensin-aldosterone system, your body, being a very wonderful thing, will try to compensate. So every time when you are retaining fluid, what the body does is it will try to get rid of the fluid. So how it tries to get rid of the fluid is it releases some peptides called natriuretic peptides. Natriuretic peptides does the opposite of renin-angiotensin-aldosterone. Renin-angiotensin-aldosterone, what does it do? Retains salt and water. Natriuretic peptides will cause your kidneys to lose salt and water. So it's doing the exact opposite, which is good in heart failure because that helps to reduce the fluid overload. So the body has some natural natriuretic peptides, such as the atrial natriuretic peptide secreted by the atria and the brain natriuretic peptide secreted by the ventricles, both causing natriuresis, loss of salt, loss of sodium and water. So when you have heart failure, the brain BMP or the brain natriuretic peptide will actually go up. And that can serve as a useful marker for you to diagnose heart failure as well. Because in a patient, if you have high BMP, that indirectly tells you, okay, this patient's body is trying to compensate for fluid overload, is trying to compensate for the heart failure by trying to get rid of fluid. That is why his BMP is high. So that is a clue that the patient is having heart failure. So if you measure BMP levels and it's high, that helps in the diagnosis of heart failure. In fact, BMP should be the first step in the diagnosis of heart failure. Because when you do the BMP, if the BMP is high, then you should go and do the echo. In our practice, since BMP is not very commonly available, we go for an echo straight away, which is not correct because sometimes you can have heart failure with a normal echo. Because you have an entity called heart failure with preserved ejection fraction, where your ejection fraction can be completely normal. So those sort of heart failures can get missed if you straight away go for an echo. But if you do a BMP, then you know this patient has heart failure. And then if you go and do the echo and it is normal, then you know this patient is having heart failure with a normal echo, which can be heart failure with preserved ejection fraction. So elevated BMP definitely helps in the diagnosis. We also have a better test called the NT-proBNP. So next time for your exam, you might get elevated NT-proBNP helps in the diagnosis. Definitely yes. So both BMP and NT-proBNP help. NSAIDs worsen the condition. Yes, because what happens is NSAIDs will cause vasoconstriction of the blood vessels supplying blood to the kidneys. So what it's going to do is, even though your kidneys are actually should be getting a normal amount of perfusion, NSAIDs will reduce the perfusion to the kidneys. So when the NSAIDs reduce the perfusion to the kidneys, your poor kidneys will try to compensate by activating this system. So what is that going to do? It's going to precipitate fluid retention and it's going to precipitate fluid overload, which is why you should be very careful when you're using NSAIDs and you should try to avoid NSAIDs as much as possible in patients with heart failure. So that is again true. Furosemide improves the survival. So when we talk about diseases in medicine and their treatment, we talk about drugs with survival benefit and drugs without with symptomatic benefit. So drugs with survival benefit are drugs that will basically improve or increase the duration which the patient will live, or they will improve the they will reduce the patient's mortality. Symptomatic drugs is not going to improve the patient's mortality, but it will make the patient feel better. So both of these drugs are useful. I mean, just because they are only symptomatic and don't have a survival benefit, it is not that you should use them. You have to use both these classes of drugs. You have to use drugs with mortality benefit. You have to use drugs with symptomatic benefit also. But we need to know which are which. So when we come to the treatment of heart failure, there are several pillars of treatment. One of the main pillars of treatment is blocking this renin-angiotensin-aldosterone system. So drugs that block it are things like AC inhibitors or ARNI. So AC inhibitors are drugs that have mortality benefit or survival benefit. Another important drug is the mineralocorticoid receptor antagonist such as spironolactone. So spironolactone also helps to improve the survival. Beta blockers. So beta blockers can reduce the sympathetic overdrive and that can reduce the myocardial demand. Because when we talk about heart failure, again, it's a mismatch between the myocardial demand and the supply. So we can reduce the demand by giving beta blockers, and that also improves the survival. And one of the major new drugs that improve survival are your SGLT2 inhibitors. So those are the drugs that have survival benefit. AC inhibitors or ARNI, that is angiotensin receptor neprilysin inhibitors, those are basically drugs that block the renin-angiotensin-aldosterone system. In addition to that, you can also have beta blockers, mineralocorticoid receptor antagonists like spironolactone, and of course, SGLT2 inhibitors like empagliflozin. Those are the drugs that improve survival. Furosemide is a diuretic. It doesn't improve survival, but it has a symptomatic benefit. It helps the patient to feel better, but it doesn't improve the survival. Again, digoxin improves the symptoms, but doesn't improve the survival. So drugs that have survival benefit, drugs that don't have survival benefit, but have symptomatic benefit are furosemide and digoxin. So your last term is wrong because furosemide doesn't improve survival. It is only a symptomatic drug. So there's a question, could you please explain how BNP gets elevated? Yeah. So what happens in heart failure is you start retaining salt and water, right? You start retaining salt and water. So what does the body do? The body will try to compensate this by getting rid of salt and water. So when we look at this pathway, the action of these chemical substances like angiotensin 2, aldosterone retain salt and water at the renal tubules. So the body secretes a chemical that will excrete salt and water at the tubules so that you can get rid of the fluid overload. So the chemical that causes this are the natriuretic peptides. Just like the name suggests, natriuretic, it causes loss of salt as well as water. So one of these natriuretic peptide is your brain natriuretic peptide, which is secreted by your ventricles. So that is how the BMP levels go up in heart failure. So any other questions? All right. So if you have questions, please do ask, right? All right. So let's go to the next one. So the next one is 53-year-old man presenting with central chest pain. So easy one. So ECG shows ST elevation in leads 2, 3, and AVF regarding the clinical scenario. So can someone tell me which coronary artery is involved in this patient? Which coronary artery has been affected in this patient? Any guesses? Is it the right coronary, left anterior descending, left circumflex? So the ST elevation is in 2, 3, and AVF. If you have ST elevation in 2, 3, and AVF, yes, it's the right coronary artery causing an inferior ST elevation myocardial infarction. All right. So the do you need troponin to make a diagnosis? So any answers to this one? This is the easy one.
No.
Yeah, so you don't need it. So for you to diagnose a STEMI or a ST elevation myocardial infarction, all you need is an ECG. If your ECG is showing an ST elevation, that is STEMI. You don't need any sort of a TROP-I or anything else to make the diagnosis. You can just confirm your diagnosis then and there. You can start treating the patient then and there. So when you get a STEMI, you have to treat with reperfusion, either with thrombolytic therapy, or you have to go for a percutaneous intervention. So you can start the treatment straight away without having to wait for a cardiac markers. So the first step is false. You don't need it, right? Sublingual GTN has a prognostic benefit. So again, when it comes to myocardial infarction, there are drugs that have prognostic benefit so prognostic benefit is the same as survival benefit. So drugs with mortality benefit, drugs with survival benefit, drug with prognostic benefit, all are referring to the same thing. All right. So in MI, the drugs that have prognostic benefit are your thrombolytic agents like tenecteplase, alteplase, or streptokinase. Your percutaneous intervention, that is basically you do an angiogram and put in a stent. So that has a prognostic benefit. Antiplatelets like aspirin, clopidogrel, statins like atorvastatin, AC inhibitors, and beta blockers. So those are the drugs that have prognostic benefit slash survival benefit slash mortality benefit. Then there are also some drugs that don't have a prognostic benefit, but can be helpful to control the symptoms. So one of the main symptoms in a STEMI is the severe pain. So to control the pain, you can give pain relief such as sublingual GTN or morphine. Those don't improve the mortality, but they have symptomatic benefit. So B is false because it has only a symptomatic benefit. Thrombolytic therapy is superior to PCI? Again, absolutely not. PCI is definitely better than any thrombolytic, whether it's tenecteplase, alteplase, streptokinase. No, PCI is the best. Percutaneous intervention is always the best, which is why if you have available facilities, you should always go for PCI. There's no doubt there. Just go for PCI. But if you don't have the facilities, but if you can still transfer the patient within 120 minutes, again go for PCI. But if your transfer is taking more than 120 minutes, then it is better to go for thrombolysis because time is muscle. The more time you waste, the more muscle in your myocardium or your heart that gets killed. So if PCI is not readily available and it's taking more than 2 hours or 120 minutes, that is only condition where we consider thrombolytic. Every other place, percutaneous intervention is the best. So that is correct. Caused by 100% occlusion. So yes, so ST elevation MI can be caused by 100% occlusion. But even occlusions, any occlusion more than 50% can technically cause a acute coronary syndrome. So acute coronary syndrome can be unstable angina, non-STEMI, or STEMI. Now, STEMI is due to near total occlusion. So usually it's something more than 90%. It doesn't always have to be 100%, but when you get 100% occlusion, you're definitely going to get a STEMI. You're not going to get a non-STEMI or an unstable angina. All right? So that is correct. It is due to eruption of an atherosclerotic plaque. Yes. So what happens is your blood vessels they are like pipe-like structures. They allow the blood to flow through it. So what happens is you get a plaque, atherosclerotic plaque that sort of narrows the lumen. Then what happens is sometimes this plaque can rupture. So when the plaque ruptures, it's going to block the entire lumen. So that is how you get a STEMI, rupture of an atherosclerotic plaque. A stable atherosclerotic plaque, that is only going to cause something like chronic coronary syndrome or stable angina, where you have chest pain on exertion. But when it ruptures, that is when you start getting things like STEMI. So that is again true. I hope that is clear. So if you have any questions, please do ask. Yeah, so there's a question in STEMI, does that area of the area muscles die? Yes, that is the end result. So when you get a STEMI, if you don't treat, so if you go back to your pathology, if you go to your Robinson, there's a chapter on the heart. So what they say is once it goes beyond 12 hours of ischemia, there's irreversible damage. But if you can reperfuse that part of the heart, either by thrombolysis or by percutaneous intervention within 12 hours, you can save that heart muscle. That is why we say time is muscle. But if you don't intervene in that period, and if your muscle is ischemic for a long period of time, unfortunately, that area of the muscle is going to die. So the answer to your question is, it's not necessarily going to die. It's going to die if you don't reperfuse immediately. All right. Any other questions? Okay. So let's go to the next one. All right. So which of the following are seen in tuberculosis? All right. So any guesses? Cervical lymphadenopathy with sinus formation, diaphragmatic paralysis, pyrexia of unknown origin with splenomegaly, apical bronchiectasis, and aspergilloma. So tuberculosis is a very important infection that you all need to know properly because it's very, very common in Sri Lanka. If you go to any medical ward at any given time, I can assure you there are at least 4 or 5 patients with tuberculosis or at least with suspected tuberculosis. Now, the thing about tuberculosis is that it can affect any part of your body, right? It can affect any part of your body, starting from your lungs to your brain to your heart to your joints. Anything can be involved. It's a multisystemic disease. So you can have pulmonary TB with the involvement of the lungs, or you can have extrapulmonary TB with involvement of other organs. So cervical lymphedema with sinus formation, that is absolutely true because you can get tuberculosis of your lymph nodes. And when we talk about tuberculosis of lymph nodes, cervical lymph nodes are one of the commonly involved lymph nodes. So cervical lymphadenopathy is absolutely correct. Diaphragmatic paralysis. Now, diaphragmatic paralysis is a bit of a tricky stem. Diaphragmatic paralysis, or diaphragm is a muscle of breathing which is supplied by the phrenic nerve, right? So your phrenic nerve runs through the mediastinum. Now, when you have a pathology that is affecting your phrenic nerve, that can cause a diaphragmatic paralysis. So classically, when we talk about lesions involving the phrenic nerve, we are mainly talking about malignancies. So things like lung cancer can infiltrate and damage the phrenic nerve, and that can cause diaphragmatic paralysis. Infections don't technically infiltrate the phrenic nerve. So infections don't commonly infiltrate the phrenic nerve and cause a diaphragmatic paralysis. So tuberculosis being an infection, infiltration of the phrenic nerve is a bit rare. But there's a catch. So mediastinal lymph nodes, right? Since you can get generalized lymphadenopathy due to tuberculosis, you can get enlargement of the mediastinal lymph nodes. That is why when you do a chest X-ray in some of the TB patients, you see bilateral hilar lymphadenopathy. Now these enlarged lymph nodes, they can compress the phrenic nerve and cause a diaphragmatic paralysis. So which of the following are seen in tuberculosis infection? I think we can take it as true because tuberculosis can cause mediastinal lymph nodes and that can compress the phrenic nerve. So it is not sort of direct, but due to an indirect thing. So this is sort of a stem which you can even consider leaving because some examiners might consider it true, thinking that the mediastinal lymphadenopathy is caused by TB, which can cause diaphragmatic paralysis. Some might take it as false, thinking that it's not directly causing this. But it is definitely seen. So I think you can take it as true. Pyrexia of unknown origin with splenomegaly. So tuberculosis is definitely one of the leading causes of pyrexia of unknown origin. Pyrexia of unknown origin is when you have fever for more than 2 weeks and you have not found a cause despite 3 days or more of extensive investigations. So TB is one of those conditions. Although we study it in detail, once you go start practicing, it's very difficult to diagnose sometimes. It's very difficult to get a microbiological confirmation. So most of the patients with PUO in Sri Lanka end up having tuberculosis. So that is true. Splenomegaly is also well recognized in tuberculosis. Apical bronchiectasis, yes, because tuberculosis has a predilection to involve the upper lobes. So upper lobes can be involved, and a complication of tuberculosis is permanent damage to your airways. So just like you have blood vessels carrying blood, you have your bronchi carrying air to your lungs. When you have infections that damage this wall, you can get abnormal permanent dilatation of these airways. Abnormal permanent dilatation of the airways is called bronchiectasis. And tuberculosis can cause bronchiectasis and it can affect the upper lobes. Other conditions that can cause upper lobe bronchiectasis or apical bronchiectasis include things like cystic fibrosis. Aspergilloma is a fungal infection. So aspergilloma will affect a pathological lung. So when you have a lung that has got damage by things like cancer, tuberculosis, vasculitis, sometimes you can get cavities or big holes in the lung. And when you get these cavities in the lung, this aspergillus can go and colonize and form a fungal ball. This fungal ball is called aspergilloma. So when you have tuberculosis cavities, it can lead to aspergilloma. but that is again not a direct thing. So tuberculosis causes tuberculosis cavity, and cavities can be colonized by aspergillosis. So that is again a tricky one. That is something you can that is something that again you can leave out, or I would mark it as false, because aspergilloma is not typically seen in the tuberculosis infection. It is seen as a complication of tuberculosis. Tuberculosis can cause cavities. Cavities can get infected by aspergillosis. So there's a question, why is TB more commonly seen in the apical areas? So TB can affect any part of the lung. Apical areas are more affected because of the anatomy, because of the direction of the airways. The right apex is more affected because that is the most undeviated. So when the trachea moves, it's least deviated to the right side, and the air mostly gets aerated to the upper zones of the lung. So as a result, they have a better concentration. The bacteria gets more concentrated in the upper zones, which is why you get apical involvement. All right. So any more questions? Okay. So let's go to the next one then. Causes for hemoptysis, again an easy one. Causes for hemoptysis include tuberculosis, mitral stenosis, idiopathic pulmonary fibrosis, leptospirosis, and bronchiectasis. Yes. So tuberculosis is a classical lung infection where you can get hemoptysis. In fact, in our setting, if any patient comes to us with prolonged fever, cough, and hemoptysis, tuberculosis is basically one of the most important differential diagnoses that you have to exclude. It is a very, very likely diagnosis if the patient comes with hemoptysis. Tuberculosis can damage the airway, can erode into the airway, can cause damage to the airways and the lung parenchyma, and hemoptysis is quite common. What about mitral stenosis? Can mitral stenosis cause hemoptysis? Yes, it can. So how does that happen is mitral stenosis is basically when the valve between your left atrium and the left ventricle is not opening up properly. So when the valve between the left atrium and the left ventricle are not opening up properly, blood is collecting in the left atrium. So what's going to happen is your left atrium is going to dilate because this left atrium is unable to push the blood into the left ventricle. So since it's not pushing the blood into the left ventricle, blood will collect in the left atrium. So the left atrium will enlarge. Now when the left atrium enlarges, there is backflow of the blood back to the lungs. Because we know oxygenated blood from the lungs will come back from the pulmonary veins into the left atrium. So when the pressure in the left atrium goes up, pressure in the pulmonary veins go up, and there's congestion of the lungs. So when you have congestion of the lungs, that can cause pulmonary edema. So you can have cough, you can have shortness of breath, paroxysmal nocturnal dyspnea, and also this flooding of the lungs with fluid can again cause rupture of capillaries, and it can again cause hemoptysis. So mitral stenosis is again a well-recognized cause of hemoptysis. What about idiopathic pulmonary fibrosis? Yes, so idiopathic pulmonary fibrosis is a fibrotic lung disease. So it's a lung disease where there is fibrosis of the bases of the lung. So when there's fibrosis of the bases of the lung, the classical symptoms that you're going to get is progressively worsening shortness of breath. So you're going to be dyspneic and you're going to get a dry cough. So progressively worsening shortness of breath, dry cough, and you will have clubbing. So these are three main things in idiopathic pulmonary fibrosis. And when you auscultate, you get bibasal fine crepitations that don't improve with coughing. So those would be the main four clinical features. It doesn't cause hemoptysis directly, but what happens is over a long period of time, it can cause traction bronchiectasis. So even idiopathic pulmonary fibrosis can lead to bronchiectasis, and that can cause hemoptysis, but not directly. So we can take the answer as false. Leptospirosis, again, you should be very familiar with leptospirosis. One of the common complications of leptospirosis is pulmonary hemorrhages. So any condition that causes pulmonary hemorrhages like leptospirosis, Wegener's granulomatosis can all cause hemoptysis. And the last is bronchiectasis. So you can get bronchiectasis due to various reasons like tuberculosis, cystic fibrosis, structural defects, genetic conditions like cartilaginous syndrome. So in bronchiectasis, this inflammation of the airway will damage the surrounding blood vessels and you can get bleeding into the airway. So hemoptysis is actually a very, very characteristic, very well recognized symptom of bronchiectasis. So that is absolutely true. So except idiopathic pulmonary fibrosis, the rest is true. All right, next question. Any guesses? So SAG. SAG is serum ascites albumin gradient. So it is an investigation that we do in patients with ascites. So when we get a patient with ascites, the ascites can be due to transudative causes or exudative causes. So one way to differentiate between that is to do the serum ascites albumin gradient. So what we do is we do a peritoneal aspiration where we pass a needle into the peritoneal cavity, draw out some ascitic fluid, and then we send it for investigations. So when we investigate the ascitic fluid, you can detect the ascitic fluid albumin or the ascitic fluid protein. Also, we can measure the serum level of albumin or the serum level of protein as well. The serum level of albumin minus the ascitic level of albumin is what we call the serum ascites albumin gradient or SAG. Serum ascites albumin gradient is the serum albumin minus the ascitic albumin. So how do we interpret this? So this is how we interpret it. Correct? So when we have, when we look at the SAG, right? So when you look at the SAG, the serum ascites albumin gradient, if it is less than 1.1 gram per deciliter. So when your SAG is low, then you should start thinking of exudative pathologies. So you should start thinking of things like biliary leak. So basically, you can get a damage to the biliary system and you can get bile leaking into your ascitic fluid. Nephrotic syndrome, pancreatitis, peritoneal carcinomatosis. So peritoneal carcinomatosis is when you have metastasis to the peritoneum. So all of these conditions can cause a low SAG, that is a SAG less than 1.1. And of course, the infections. So infections like tuberculosis and secondary bacterial peritonitis, those can cause a SAG less than 1.1. So the important ones to remember are the infections like secondary bacterial peritonitis, biliary peritonitis, pancreatitis, and of course the malignancy like peritoneal metastasis. When your SAG is high, when your serum ascites albumin gradient is more than 1.1, there you should start thinking of the transudative pathologies. Again, to narrow down your differential, you can look at the ascitic fluid protein. So with a high SAG, if you have a low ascitic fluid protein less than 2.5, think about things like cirrhosis, late Budd-Chiari, or massive liver mets. So Budd-Chiari syndrome is a condition where you have thrombosis of the hepatic vein. So basically, you have a thrombus in the vein that drains your blood from the liver. So when you have a thrombosis or a block in the veins that drain blood from the liver, you're going to end up with ascites, and that is going to have low protein as well. You can also have a SAG more than 1.1, suggestive of a transudative ascitic fluid, but with the ascitic fluid protein more than 2.5. So if the ascitic fluid protein is more than 2.5, cirrhosis becomes less likely because in cirrhosis, you would accept the protein to be low. So here you can think of other transudative conditions like heart failure, early Budd-Chiari syndrome, IBC obstruction, or sinusoidal obstruction syndrome. So if we go back to our question, SAG of more than 1.1 gram, more than 11 grams per liter is seen in. So more than 11 grams per liter or more than 1.1 grams per deciliter. So if the SAG is more than 11 grams per liter or more than 1.1 grams per deciliter, that means we are dealing with a transudative cause. So TB peritonitis is an infection. So infections are exudative. So your SAG is going to be low. So that is false. Portal hypertension. Portal hypertension is due to cirrhosis. So cirrhosis portal hypertension is a transudative cause. So that is going to have a SAG more than 11. That is true. Acute pancreatitis is an infection and inflammation. So that is exudative. So your SARG is going to be low. So that is false. Right heart failure, again transudative. So your SARG is going to be more than level. So that's going to be true. Peritoneal carcinomatosis is malignancy. So that is again exudative. So exudative means it should be less than 11. So the only ones where it's more than 11 is the transudative causes, and the only transudative causes here are your portal hypertension and your right heart failure. So the rest of them are false. So I hope that is clear. Any questions there? All right. So in the absence of questions, I'll move on to the next one. Please feel free to ask any questions. Clear your doubts, right? I mean, there's no point going for the exam with doubts. So clear your doubts. So yeah. So if you have any questions, you can unmute yourself and ask me, or you can put a message on the chat box. All right. Yeah. So there's a request to share the presentation. I will do that. Right. So at the end of the lecture, I'll share it on the WhatsApp group. All right. So next one. Features suggestive of hemochromatosis in a patient with cirrhosis are. So any question, any guesses there? All right. So hemochromatosis is a condition. It's a genetic condition where you have a disorder of iron metabolism. So our body should have a normal amount of iron, because just like other minerals, iron is also very, very crucial for the action, for the function of the body. And what the main function of iron in the body is to form hemoglobin, which is important for carrying oxygen around the body. But there are certain genetic conditions where the metabolism of iron is affected. Hemochromatosis is one of them. So you can have primary hemochromatosis where you have a defect in the gene called HFP gene. So when you have a defect in the HFP gene, that will cause accumulation of iron in the body, and the iron levels in the body will start going up. There's also a condition called secondary hemochromatosis where your iron levels in the body go up secondary to things like blood transfusion. Both, either if it is primary or even if it is secondary, the main effect is you have too much of iron accumulating in your body. So when you have too much of iron accumulating in the body, it can go and get deposited in various organs. All right. So the liver is one of the important organs where iron gets deposited, and it can cause liver damage. So when you have iron causing liver damage over a long period of time, it can cause permanent irreversible damage to the liver, leading to fibrosis of the liver, and that can lead to cirrhosis. So when we talk about cirrhosis, the common causes of cirrhosis are things like non-alcoholic fatty liver disease, as well as alcohol, hepatitis B and C. And those would be the main common causes of cirrhosis that we come across. But you can also come across genetic causes like hemochromatosis and Wilson's as well, which is why we need to ask a family history of cirrhosis when we evaluate a patient with cirrhosis. So now the question is asking us, what are the other features in a patient where we will suspect hemochromatosis? So now, when you get a patient with hemochromatosis, the liver is not the only organ where the iron goes and deposits. It can get deposited in various other organs. So it can get deposited in the heart. So when it gets deposited in the heart, you're going to get cardiomyopathy, you're going to get cardiomegaly, and you're going to go into heart failure. It can get deposited in your skin. So you can get pigmentation of the skin. In fact, you get a characteristic bronze pigmentation of your skin. It can also go and get deposited in the joints. It can get deposited in the joints and cause arthritis. It can also get deposited in your pancreas, and it can cause pancreatic failure. So when you have pancreatic failure, you know the pancreas has two main functions, the exocrine action and the endocrine action. Exocrine action is to secrete digestive enzymes to absorb your food. So when you have deficient of enzymes, you're going to get malabsorption and diarrhea. And other one is the endocrine action, which is secretion of insulin. So when you have a deficiency of insulin, you're going to end up with diabetes mellitus. So hemochromatosis is a multisystemic disease where you have all these organs being involved. So you can have cirrhosis, you can have heart failure, you can have pancreatic failure and diabetes, and you can have skin pigmentation. Also, you can have arthritis. So those are some of the features of hemochromatosis. How you would treat hemochromatosis, how you would diagnose hemochromatosis is you can look for this characteristic gene called the HFE gene. Another one is you can take the transferrin saturation and the ferritin, and those will be very high. How you treat is you can do phlebotomy where you remove the patient's blood so that you can reduce the patient's iron levels. So, I mean, I'm sure you're familiar with iron deficiency anemia, right? So iron deficiency anemia, one of the causes is bleeding. Now, in a patient with high levels of iron, we want the iron to go down. So what we do is we purposefully do bleeding, right? So we do phlebotomy so that we can reduce the patient's iron levels, all right? So that is one of the ways that we can treat. Diabetes mellitus. So yes, pancreatic failure can cause diabetes mellitus. That is true. Splenomegaly. So features suggestive of hemochromatosis in a patient with cirrhosis or splenomegaly. That's again a tricky question because hemochromatosis per se doesn't cause splenomegaly. Hemochromatosis can cause iron deposition in the spleen, but the splenomegaly here is due to portal hypertension. That is cirrhosis causing portal hypertension causing splenomegaly. So in any cause of cirrhosis, you can get splenomegaly. It's not particularly due to hemochromatosis. So that is not correct. Bronchiectasis is not seen in hemochromatosis. So if you get if you get cirrhosis with bronchiectasis, you should think of a pathology that is affecting both your liver and your lungs. Can anyone think of a condition that can affect your lungs and the liver? Any guesses? Quite a rare condition. Yeah, so you have this condition called alpha-1 antitrypsin deficiency. So alpha-1 antitrypsin deficiency can affect both your lungs and the liver. So hemochromatosis doesn't cause bronchiectasis. That is false. Vitiligo. Vitiligo is an autoimmune condition where you have hypopigmented patches in the skin. So in a patient with cirrhosis, if you see vitiligo, you should think of autoimmune causes of cirrhosis, which is cirrhosis due to autoimmune hepatitis. So, I mean, among the causes of cirrhosis, you have alcohol, non-alcoholic, hepatitis B, C, hemochromatosis, Wilson's disease, autoimmune hepatitis, primary biliary cholangitis, primary sclerosing cholangitis, iatrogenic causes due to drugs, right? So from these causes, vitiligo will support autoimmune hepatitis, not hemochromatosis. Hemochromatosis, you get the opposite of vitiligo. You get hyperpigmentation, right? So the only true things here are cardiomegaly and diabetes mellitus. So that's a question. Thalassemia treatment can cause. Yeah. So thalassemia treatment is blood transfusion. I think that's what you're referring to, right? So you treat thalassemia by recurrent blood transfusion. So when you give recurrent blood transfusion, that can cause iron accumulation in the body because blood contains iron. If you're pumping iron into these patients, the iron levels go up, right? So thalassemia, yes, treatment of thalassemia with blood transfusion can cause secondary hemochromatosis. All right. So next one, lupus nephritis. So I would like to see a bit more answers. I hope you all are not getting too sleepy because you all were answering in the beginning. Now I'm not seeing many answers. So can any guesses on this one? Lupus nephritis. It's a cause of nephrotic syndrome seen in 90% of patients with SLE. Will not cause end-stage kidney disease. There's a high risk of relapse. There are 6 histological subtypes. Any guesses? I hope that you can see hear me. All right, fine. So there are answers coming in. So fine, good. All right. So okay. So lupus nephritis is a cause of nephrotic syndrome. So the answer is, so there are some mixed answers. There are false, true, false, true. Yeah. So it is a cause of nephrotic syndrome, right? So when you talk about nephrotic syndrome is a condition where you have damage to the kidneys and where you lose protein with your urine. Common causes in children are things like minimal change disease. When it comes to adults, the causes are diabetes mellitus, amyloidosis, focal segmental glomerulosclerosis, malignancies causing membranous nephropathy, and another important cause is SLE. So SLE, lupus nephritis, can present with nephrotic syndrome. In fact, nephrotic syndrome is one of the typical presentations of a lupus nephritis. It is seen in 90% patients with SLE. So, I mean, you might have come across patients with SLE. Most of them, I mean, a considerable amount of them do have renal involvement, but 90% is way too much. Not all patients with SLE have renal involvement. If you take things like cutaneous involvement, like photosensitive rashes, loss of hair, oral ulcers, yes, a very huge proportion of the patients have it. But when it comes to lupus nephritis or renal involvement, it's a lower percentage. So it's only about 40 to 50% that have uh, renal involvement in SLE. So 90% is too much, so that is false. Will not cause end-stage disease? Yeah, so the answer is false. Lupus nephritis can cause end-stage kidney disease. In fact, if you have patients with SLE, one of the main things that you are very concerned about is the renal involvement. Because if you don't treat the renal involvement with immunosuppressive therapy, these patients can end up with end-stage kidney disease and they might need dialysis or even kidney transplant. Unfortunately, we do get a lot of patients coming in for dialysis who have had SLE in the past. So that is false. It is a cause of end-stage kidney disease. There's a high risk of relapse during pregnancy. Yes, there is. Because patients with SLE, before they go into pregnancy, we have to make sure that they are in remission because we are worried about relapses during pregnancy. SLE can relapse during pregnancy, and that can be very problematic. It can be problematic to the mother as well as it can be problematic to the baby, right? So to prevent that, we have to make sure that the patient is in remission. So things that increase the risk of relapse during pregnancy are if the patient is having active disease before pregnancy. I mean, if the patient becomes pregnant while having active SLE, the chance of relapse is very high. Another thing is very high active disease. And another important one is this lupus nephritis. If a patient is having lupus nephritis and the patient becomes pregnant, there's a very high chance the disease will relapse. So those are the important risk factors for relapse of SLE. Having active, those are the risk factors for relapse of SLE during pregnancy. Having active disease prior to pregnancy and presence of lupus nephritis. So that is true and most of you have marked it true. There are 6 histological types. Good, yes. All of you have marked it correct. There are 6 histological types. You don't have to sort of know in detail about the histological types. But if you are interested, these are the 6 histological types. Class 1 is minimal mesangial. Class 2 is mesangial proliferative. Those are very sort of good, I would say, good forms of SLE nephritis to have because those don't damage your kidneys much and those do not need sort of aggressive therapy. What we are mainly worried about is class 3 and 4, which is proliferative glomerulonephritis, class 3 being a focal one and class 4 being a diffuse one, both of which are very aggressive and can cause significant damage to your kidneys. Class 3 and 4 have to be aggressively treated with immunosuppressive therapy. Class 5 is membranous lupus nephritis. That is the type that presents with the nephrotic syndrome. So I said lupus nephritis can present with nephrotic syndrome. So it is a membranous lupus nephritis that presents with nephrotic syndrome. All right. So I think one of the stem cells can present as nephrotic syndrome. That is due to class 5. Class 6 is advanced sclerosing lupus nephritis. That is basically the end stage of lupus nephritis where you have significant damage and fibrosis to the kidneys. So the patient has gone into end stage renal disease. So these are the 6 histological subtypes. Fine. Last one regarding IgA nephropathy. Last one for the true false, right? We have some SBAs also. So regarding IgA nephropathy, any guesses? IgA nephropathy, Yeah, any more answers? Okay, fine. So this might not be a topic you're very familiar with. So IgA nephropathy is a form of glomerular nephritis, right? It's a disease that can affect your kidney. Basically, what happens in IgA nephropathy? So basically, what happens in IgA nephropathy is following an infection, you have IgA-mediated damage to your kidneys. Now, IgA is an immunoglobulin, which is very important for your body. It helps in the protection against infection. It is mainly found in secretions, right? So IgA plays a very important role in the body. But sometimes what happens is, due to certain things like infection, your immune system can go sort of haywire, and your own immune system can attack your own tissues. So here your IgA starts attacking your kidneys. So what happens is, it usually happens soon after an infection, usually things like an upper respiratory tract infection. So you might get something like fever, cough, cold, and the patient can get IgA nephropathy after 1 to 2 days. So it occurs immediately following an infection. Patients present with glomerular nephritis with significant hematuria. They are very notorious, they are very famous for causing gross hematuria. They're usually very self-limiting illnesses. They will cause gross hematuria, which can be scary, but not very damaging to the kidneys. And after some time, these symptoms will sort of improve and the patient gets better on their own. Some patients rarely can get severe kidney damage. They can get severe glomerular nephritis, hypertension, acute kidney injury, and significant damage to the kidneys. And some of them can unfortunately go into end-stage renal disease as well. Usually, since it's a self-limiting disease, we don't need to treat it. We just need to symptomatically treat the patient, like manage the patient's high blood pressure. Rarely, if they are not responding, if they're rapidly worsening, you might consider immunosuppressive therapy like steroids. All right. So let's go to the question regarding IgA nephropathy. Occurs 10 to 14 days following an upper respiratory tract infection. Yes, some of you have answered it correctly. That is false, because as I mentioned, it occurs immediately following an infection. So IgA nephropathy occurs about 1 to 2 days after an infection. What occurs 10 to 14 days after an upper respiratory tract infection? Yeah, that's post-streptococcal glomerulonephritis. So you can get a streptococcal infection, like a streptococcal sore throat or a streptococcal wound, and following that you can get a glomerulonephritis. That usually occurs after about 10 to 14 days, not IgA nephropathy. B, that's a bit of a difficult one, known to occur in CLCD. So IgA nephropathy can occur following infections, but IgA nephropathy can also be related to other systemic diseases as well. So some of the systemic diseases where you can get IgA nephropathy, things that you can remember are things like chronic liver cell disease, celiac disease, which is autoimmune disease of the bowel, HIV infection. So HIV can cause IgA nephropathy, and also other hematological malignancies. So although IgA nephropathy classically occurs following an infection, you can also get IgA nephropathy occurring in the setting of CLCD, celiac disease, and hematological malignancies. So that is also an important thing to remember. It is the commonest cause of glomerulonephritis worldwide. Yes, it is. One of the commonest causes in the past was post-streptococcal glomerulonephritis. But now it's not that common because everyone uses antibiotics. So the moment you get an infection, antibiotics, augmentin, this, that. So everyone is self-treating infections. So post-streptococcal glomerulonephritis is not that common. IgA nephropathy has come up, and now that is the commonest cause of glomerular nephritis. Commonest presentation is RPGA. So RPGA, that is again a difficult one. So RPGA is rapidly progressive glomerulonephritis. It is a form of glomerulonephritis where the patient suddenly goes into acute kidney injury. So very, very devastating, severe glomerulonephritis. You usually get it in diseases like Goodpasture's disease or ANCA vasculitis, such as Wegener's granulomatosis or eosinophilic granulomatosis with polyangiitis or Churg-Strauss syndrome. So those are the ones where you classically get RPGA. Goodpasture syndrome, Wegener's granulomatosis, Churg-Strauss syndrome. IgA nephropathy can cause RPGA. I won't say that it doesn't. It can cause. It is a recognized cause. But the commonest presentation is RPGA is absolutely false. Commonest presentation is glomerular nephritis with gross hematuria. Isolated hematuria needs treatment. No, it doesn't. Because isolated hematuria, all we need to do is observe the patient and treat the patient symptomatically. If the blood pressure goes up, you can treat with some antihypertensives like ACE inhibitors. In fact, gross hematuria is a good prognostic sign in IgA nephropathy. In a patient with suspected IgA nephropathy, if the patient is having gross hematuria, that is a good thing. That means the patient is most likely going to recover. That is again a common stem that is asked in exams. Gross hematuria is a bad prognostic sign. And when you see that, you are tempted to answer that as yes, right? Gross hematuria is bad. Not in IgA nephropathy, right? In IgA nephropathy, gross hematuria is actually good. It's a good prognostic sign. All right, any questions? Okay. All right. So that comes to the end of the true false. So I started with the true false because I feel like that's the more difficult one, and I wanted to finish that off before you get sleepy. So next we'll go on to the SBS. So I want to see more answers now, right? So true false, yeah, some stems are difficult to answer, and as I mentioned before, you don't have to answer every step, right? Make sure that you answer about 70 to 80% of the steps, right? So that is about, you should answer minimum of 3 in each as much as possible. So 3 to 4 is okay. There's always going to be a difficult step which you can avoid, right? All right, so let's go to the SBS, and I think I'll see more answers in this one, right? All right, so a 55-year-old woman presented with shoulder pain and weakness that increased towards the end of the day. So she's having weakness of her body, and that is worsening towards the end of the day, right? So note that her weakness is towards the end of the day. Acetylcholine receptor antibodies were positive, and the EMG shows a reducing potential with repeated muscle contractions. What is the best treatment to improve her symptoms? Okay, before telling the best treatment, can someone tell me what the diagnosis is?
Myasthenia?
Yeah, very good. So it's myasthenia gravis, right? So myasthenia gravis is a neuromuscular junction pathology where you have a deficiency of acetylcholine acting. Now, when you look at the neuromuscular junction, signals will go from your nerve to your muscle through a neurotransmitter called acetylcholine. This acetylcholine will go and bind to the acetylcholine receptors at the muscle. Here, what happens is your antibodies have destroyed this, not destroyed, your antibodies have bound and blocked these acetylcholine receptors. As a result, your acetylcholine can't go and act on the muscle, so your muscle is not able to contract. So that is what happens in myasthenia gravis, right? With repeated contractions, it gets worse because the acetylcholine gets exhausted. Right? So this is myasthenia gravis, correct answer. Now the difficult one. What is the treatment that is going to improve her symptoms? IV cyclophosphamide, IV immunoglobulin, IV methylprednisolone, oral azathioprine, or oral pyridostigmine. Any answers? You can guess. So when it comes to SBA, you have to answer everything, all right? Not like true false, you don't have negative marks here. So please don't leave SBA blank, right? So that's just going to be a waste. If you don't know, you have to guess, right? All right, so any more answers? I've seen a few on the chat. Any more? So most of the answers are fluctuating between C and E, which is very good because those are the two main answers I would consider as well. But so that's usually what happens in single best answer, right? It comes to about 2 answers, but the thing is, they are not asking you what the correct answers are. If they ask you what the correct answers are, almost all 5 of these answers are correct. But they're asking you what the best answer is. So when it comes to choosing the best answer, it becomes a bit more tricky, right? Now, when we talk about the treatment of myasthenia gravis, right? So how we treat it is, now you have a deficiency of acetylcholine acting on the muscles. So we have to try and increase the level of acetylcholine in the neuromuscular junction. Now, acetylcholine in the neuromuscular junction is broken down by an enzyme called acetylcholinesterase. So if you can inhibit the enzyme that is breaking down acetylcholine, you can increase the acetylcholine. So one way treat myasthenia gravis is to inhibit the enzyme that is breaking down acetylcholine. So those are acetylcholinesterase inhibitors. The classical drug that we use is pyridostigmine. So pyridostigmine can increase the acetylcholine levels and that can improve the symptoms. This is an immune-mediated disease, right? It's antibody-mediated disease. It's antibodies against the acetylcholine receptor. So one way of treating it is to immunosuppress the patient. If you immunosuppress the patient, you will reduce the antibodies produced against the acetylcholine receptors. That way, your acetylcholine receptors are not blocked, so your acetylcholine can act and your symptoms should improve. So ways that we immunosuppress is we can go for steroids, right? Things like prednisolone, we can use. But the problem is steroids have a lot of side effects, right? It can lead to iatrogenic Cushing's. So we don't use steroids for a long period of time. Instead, we use steroid sparing agents like azathioprine, right? So those are the main ways we manage. Acetylcholine receptor antagonists like pyridostigmine, steroids, and for the long run, steroid sparing agents like azathioprine. If the patient comes with very severe life-threatening symptoms like respiratory muscle paralysis, we can't treat using those. We have to go for immediate aggressive therapy. There we have to go for drugs like IV methylprednisolone to quickly immunosuppress the patient, or we have to go for higher, strongly immunosuppressive agents like IV cyclophosphamide and IV immunoglobulin. So now in the treatment that I gave you, I have mentioned all 5 answers. So all 5 can be used in the treatment, but the first 3 are used in myasthenic crisis. That is when the patient goes into severe myasthenia, that is with respiratory failure. So if there's respiratory failure, we can go for methylprednisolone, IVIG, IV cyclophosphamide. But this lady is not having respiratory failure. She's just having some muscle symptoms. So the first 3 answers might not be relevant to this patient, right? We are not talking about myasthenia gravis. We are talking about this patient, right? So for this patient who is not having respiratory involvement, first 3 answers might not be the best. Then we have to choose between pyridostigmine and azathioprine. So azathioprine is going to help you in the long run. It's going to immunosuppress, it's going to modify the disease, and it's going to help you recover from the illness. But what is going to help improve the symptoms is to quickly increase the acetylcholine levels, right? Because this patient is symptomatic because her acetylcholine levels are low. So the best way to increase the symptoms is to quickly increase the acetylcholine levels. And the way to quickly increase the acetylcholine level is to go for an acetylcholine acetylcholinesterase inhibitor, so that you are blocking the enzyme that is breaking down acetylcholine, so that your acetylcholine levels will go up, right? So because of that, the answer is E. That is pyridostigmine, which is going to quickly improve the symptoms by quickly increasing the acetylcholine levels. So I hope you understood that, and I hope that's not confusing. So, I mean, it's a bit of a confusing question. So please feel free to ask questions, right, guys? Don't be shy, right? I mean, the only way you can clear your doubts and get good marks at the exam is if you discuss and if you keep clearing your doubts, right? So just think about this like you're discussing with a colleague and you can ask me questions, right? Okay. All right. So next one. So let's go to the next one if you don't have questions. So again, I want to see some answers. So here we have a 33-year-old woman who's coming with a severe left shoulder pain. It increases gradually during the initial 24 hours after onset. Pain occurs 2 weeks after being administered the influenza vaccine. Important point. It is a dull pain for which she was given analgesics. However, there's some neurological involvement also. So there's mild weakness in the left shoulder movements. There's reduced bicep jerk, reduced pinprick sensation in C5 and C6. What is the most likely diagnosis? Okay, I want to see some answers. So there was a question, if myasthenic crisis, which one is the best? So if it's myasthenic crisis, IV methylprednisolone would be the best, right? That is the immediate thing to give. And IVIG, right? So IV methylprednisolone and IVIG. So we have to give both of them together. So practically we load them with methylprednisolone along with the IVIG. So it's a bit difficult to choose between those two in a single best answer. If you talk about effectiveness, IVIG is more effective than IV methylprednisolone, but we always try with IV methylprednisolone first. And if it's not responding, we usually go for IVIG. So first would be basically IV methylprednisolone. best or most effective, I would say, would be IVIG. Right. So a few more answers, please. All right. So, okay, good. So most of you have got the correct answer. So here, when you have a neurological disease, right? So this is a neurological disease, right? So when you get a neurological disease, first of all, try to localize the lesion, right? So where is the problem? Is this a upper motor neuron pathology or a lower motor neuron pathology? I think everyone should be able to answer that, right? Is this upper motor neuron pathology or lower motor neuron pathology? So what are the features of upper motor neuron pathology? Increased reflexes, spasticity, right? Upgoing planters. What are the features of a lower motor neuron pathology? Reduced reflexes, wasting, right? So is this a upper motor neuron pathology or a lower motor neuron one? Come on, guys, you have to get into this, right? Otherwise, you're not
Low
going to
motor.
learn, right? So any answers? Upper motor neuron or lower motor neuron?
Low motor.
Yeah, exactly. Good. So it's a lower motor neuron pathology. Now, when we talk about upper motor neuron pathology, we are thinking about pathologies affecting the brain, brain stem, or spinal cord. Brain, brain stem, spinal cord is upper motor neuron. Patient's plexus, radicals, nerves, neuromuscular junction, muscle, those are lower motor neuron pathologies, right? So now this is a lower motor neuron pathology now, right? So can it be a pathology in the brain, brain stem, or spinal cord? No, because if it was brain, brainstem or spinal cord, then the patient should have upper motor neuron symptoms, right? So any lesion of the brain, brainstem and spinal cord, you can exclude. So can it be syringomyelia? No, syringomyelia is a pathology of the syringomyelia is a pathology of the spinal cord. There you would have seen some upper motor neuron lesion in the lower limbs. True, you can get some lower motor neuron signs in the upper limbs, but in the lower limbs, there would be some upper motor neuron signs, which they have not mentioned. So you can exclude syringomyelia. Transverse myelitis, same thing. You're going to see some sort of upper motor neuron symptoms, particularly in the lower limbs. So the two spinal cord pathologies, syringomyelia and transverse myelitis, are out because we are not seeing any lower limb findings. There are no upper motor neuron symptoms in the lower limbs. Brachial neuritis, cervical radiculopathy, herpes zoster related neuralgia, they are all lower motor neuron pathologies and they are all possible. Now, when we talk about the lower motor neuron pathology here, we can again localize the lesion to the C5, C6, right? Because bicep jerk is lost, right? So what is the nerve root for the bicep jerk? C5, C6. Brachioradialis or the supinator jerk, C5, C6. Triceps jerk, C6, C7. Knee jerk, L2, L3, L4, right? Ankle jerk, S1, S2. So if there is loss of the bicep jerk, we know this pathology is affecting C5 and C6. So now we have localized the lesion to C5, C6 roots, right? C5, C6 roots. It is further confirmed because there's reduced sensation in C5, C6. Now we are further 100% sure, yes, this is C5, C6 nerve root. Now C5, C6 nerve root can be involved either due to cervical radiculopathy or it can be involved due to brachial neuritis, right? Herpes zoster induced neuralgia will not cause a sort of loss of reflexes. So that is out as well. Now you have to differentiate between brachial neuritis and cervical radiculopathy. Both, I would say, are correct answers in this clinical context because both can cause lesions of C5, C6. Now, the clue is 2 weeks before the patient was administered influenza vaccine. Following a vaccine, you don't get a radiculopathy. Radiculopathy is usually due to nerve root compression following trauma, cervical spondylosis. So basically when patients get old, their bones get fragile, their vertebrae sort of collapse, then they compress the nerve roots. Or it can happen due to trauma or sometimes due to infections. Following vaccines, what you typically get is a brachial neuritis. All right. So the answer here is brachial neuritis. So use that pathway when you are coming to a diagnosis in neurology, right? Neurological diagnoses are very simple, right? Always try to localize the lesion. Go back to the basics. Are we dealing with upper motor neuron or lower motor neuron lesion? If it is lower motor neuron, which part of the lower motor? Is it plexus, root, nerve, neuromuscular junction, or muscle? Then it becomes very easy. So here what you do is you can localize the pathology to the C5, C6 nerve roots. Then you have two pathology affecting the nerve roots. But in this clinical concept, in this clinical context rather, it is likely to be brachial neuritis. All right. So next one. So 76-year-old lady with a history of ischemic heart disease presented following an embolic stroke, complains of severe pain in the right side of the body. She describes it as a burning pain. What is the likely site that is affected? All right. So any answers? Which part of the brain is affected? Is it left part of the brain or the right part of the brain? So can you comment left or right? Yeah, so it's the left part of the brain that is affected. Now the question is, unfortunately, they have not asked that. They have asked what is the side that is affected? All right. So yeah, so this might be a bit of a difficult one. So let me just talk to you about the sides, right? So for you to answer this question, you need to know which parts of the brain are affected with which bodily functions, right? So now when we talk about the frontal lobe is it's involved in personality, memory, intelligence, logical decision making, and basically behavior and planning. So when you have a frontal lobe lesion, you have personality changes. Patient can have personality changes. Patient is not able to do things that they used to do before. They are unable to plan things. And basically personality changes would suggest a frontal lobe lesion. Parietal lobe is involved in language and reading. So if you have a lesion in the parietal lobe, patient will not be able to read books. Patient might not understand what you are saying. Patient might have a sensory aphasia or a Wernicke's aphasia, right? Where patient, you say something, but the patient doesn't understand that. They tell you something completely different. All right. So if you have problems in comprehension, think about parietal lobe. If there's involvement of the temporal lobe, there can be problems with speech. So patient is unable to talk properly. And also there can be problems with memory and emotions as well. Occipital lobe, as you know, is involved with vision. So following a stroke, if the patient is saying that the patient can't see properly, that means you are dealing with a lesion in the occipital lobe. All right. If you have a lesion in the brainstem, the main functions of the body like blood pressure control, heartbeat, swallowing, and all these essential functions are lost. If your cerebellum is affected, cerebellum, as you know, is involved in the coordination. So you will lose coordination, you are unable to walk properly, you start swaying from side to side. When you do the finger nose test, patient will have an intentional tremor like this. When you check for coordination, this kind of patient is unable to coordinate and do the alternative hand movements. So coordination problems are due to cerebellar lesions. So if you know the functions of the different parts of the brain, you can figure out where the lesion is when the patient comes with these problems, right? So this is an important diagram for you to know, but this still won't answer our question. So what is the lesion that is going to produce sensory loss in one half of the body? Now, if this was frontal lobe, the patient would have presented to us with personality changes. They didn't tell us that, right? If this was hypothalamus involvement, patient would have come with problems with appetite. Patient would be feeling hungry all the time, things like that. Temporal lobe, patient would come with speech problems, unable to talk properly, and again, problems with the memory. Pons is brainstem, so they will have problems with sight, diplopia, and all the body, and some of the important critical functions of the body will be affected. Pons mainly contains important cranial nerves, so they can come with cranial nerve palsies. Particularly, your seventh nerve palsy can cause a facial nerve paralysis, while your fourth nerve palsy can cause thermophagia as well, right? So cranial nerve pulses would have suggested a pontine lesion. All right. Thalamus is the one that will cause a sensory stroke, right? So when you talk about stroke, you can have both a motor impairment or a central sensory impairment. When you get a stroke that affects the sensation in one half of the body, that is due to a thalamic lesion. All right. So the answer here is a thalamic lesion or E. It's a bit of a difficult one. It's something that you need to know. If a patient comes to you with stroke and the patient is having sensory impairment of one half of the body, always think about a thalamic lesion in the opposite side. So this patient is having right side sensory problem. So the lesion is in the left thalamus. So make sure that you know this diagram well as well, because the next time you might get a patient coming with personality changes and they might ask you, where's the lesion? Then you know it's frontal lobe. They might give you a patient with visual problems. Then you know it's in the occipital lobe, right? All right. Again, this is also a bit of a difficult one, but if you know it, you know it, right? So let's see whether you have an idea. Try to guess if you don't. 36-year female who was in bereavement, that is, she's suffering from the death of a loved one. So she has lost her husband 2 weeks back, and she's presented to the emergency department with a central chest pain. Troponin was elevated. ECG shows ST elevation in the anterior leads. Transthoracic echo shows apical hypokinesia with an ejection fraction of 40. Coronary angiogram was entirely normal. What is the most probable diagnosis? All right. So any answers? Okay, good. So few of you have got the correct answer. So now the problem here is the patient has come with a chest pain. Patient has ST elevations. This is a typical presentation of a ST elevation myocardial infarction, right? I mean, patient has come with MI. I mean, that is the first thing that you should think of, right? But the problem is when you do the coronary angiogram is normal. Now, if it is a STEMI, right? If it is a STEMI or if it is a ST elevation myocardial infarction, when you do an angiogram, you have to see a block, right? There has to be a block in one of the coronary arteries, right? But here there is no block. So this can't be a ST elevation myocardial infarction. So therefore, you have to know what are the other conditions where you can get an ST elevation. So in addition to the ST elevation myocardial infarction, you can also get ST elevations in pericarditis. So in pericarditis, what happens is you get concave ST elevations in most of the leads. Now, when it's a ST elevation myocardial infarction due to ischemic heart disease, the ST elevation will be in only some of the leads corresponding to the vascular territory. For example, if you have occlusion of the right coronary artery, there will be ST elevation in 2, 3, and AVF. But in pericarditis, all the leads, there will be ST elevation. All right? And you will get a pleuritic type of chest pain. Another condition is left ventricular aneurysm. So when you get abnormal dilatation of the left ventricle, that can also cause ST elevations. Then you have a condition called Brugada syndrome. So Brugada syndrome is again a sort of a genetic disease where your heart is prone to get severe life-threatening arrhythmias. They can suddenly get severe life-threatening arrhythmias and die. A clue to the diagnosis in Brugada syndrome is you get this tented ST elevations in the anterior leads. So somewhere around V1 to V4, you get this very cold, tented like cold ST elevations, right? So these are some of the conditions where you can get ST elevations. So you have to realize that STEMI is not the only condition where you get ST. So here the answer STEMI is wrong because the coronary angiogram is normal. Pericarditis is a possibility because coronary angiogram can be normal. But here, then you should have seen the ST elevation in all of the leads. But here you see the ST elevation only in the anterior leads. So that can't be the one, right? Brugada syndrome is again wrong because Brugada syndrome, the patient will not come with chest pain. The patient will come to you with arrhythmia, all right? Aortic dissection, patients can come with severe chest pain. They can cause ST elevations, but usually they cause ST elevations in the inferior leads. That is 2, 3, and AVF. They don't cause ST elevation in the anterior leads. Here the ST elevation was in the anterior leads. So it can't be aortic dissection also. So the answer is Takotsubo cardiomyopathy. It's a very characteristic, very unique type of cardiomyopathy that occurs as a risk of stress. So when you are under severe stress, it can be physical stress, it can be mental stress. So maybe acute illness, maybe a snake bite, maybe death of a loved ones, maybe break up with your girlfriend. So any stressful condition can cause this Takotsubo cardiomyopathy. In Takotsubo cardiomyopathy, the characteristic thing is the left ventricle gets dilated like that. So when you do an echo, you will get apical hypokinesia. Your apex of the heart, now when you look at your heart, this part, the apex of your heart is not pumping blood well. It's not working well. It's dilated. So when the apex of the heart is dilated and not pumping properly, that is called apical hypokinesia. And that is characteristic of Takotsubo cardiomyopathy. So I will show you what an echo looks like in Takotsubo cardiomyopathy. So this is a normal heart where you can see the normal left ventricle. This is what happens in Takotsubo cardiomyopathy where the apical part is not contracting and it's dilated and it looks something like that. So if you're interested in how the name Takotsubo came, so the Japanese, they used to use a pot called the Takotsubo to catch an octopus. So this is a pot and the octopus will go into that pot and get trapped there. So when you do the echo, the left ventricle looks like one of those pots. So that is why we call it Takotsubo cardiomyopathy, right? So it's a very particular, very unique type of cardiomyopathy which occurs after exposure to a very stressful condition. All right. So that is a bit of a difficult one, but now I think you should be able to answer if you get it. All right. Fine. Next one. Female on thyroxine is presenting with difficulty in breathing. She also complains of pleuritic chest pain. She has elevated JVP, bilateral ankle edema and clear lungs. Blood pressure was 70/50. ECG shows narrow complexes, bradycardia, chest X-ray showed cardiomegaly. Following investigations are present. So the full blood count is normal. TSH is high. CRP, creatinine, sodium and potassium are normal. So basically, this is a hypothyroid patient on thyroxine who's coming to you with pleuritic chest pain, elevated JVP, bilateral ankle edema, clear lungs and shock. All right. So what is your diagnosis? What is the most likely diagnosis? Any answers? Is it congestive cardiac failure, mixed edema, right heart failure, cardiac tamponade, or pulmonary embolism? Okay, I can see a few answers. Any more answers? So patient with hypothyroidism coming with shock, elevated JVP, shortness of breath, and clear lungs. I can see a few answers. All right. So again, yeah. So thank you. I can see a few answers. So now again, things that you have to consider here, right? First come to what sort of a cardiac pathology are we dealing with, right? So she's having elevated jugular venous pressure, bilateral ankle edema, and clear lungs, right? And clear lungs. So that means the patient is having heart failure, but it's not a left heart failure, because if there's a left heart failure, there should be congested lungs, right? So congested lungs are what you see in left heart failure or congestive cardiac failure. Now, if this was elevated JVP, bilateral ankle edema, and congested lungs, that would have been a straightforward textbook congestive cardiac failure. Now, this patient is having clear lungs with elevated JVP and bilateral ankle edema. So most of you have thought about right heart failure, which is very good thinking, because when you have right heart failure, you have elevated JVP, right? You have an elevated JVP with clear lungs, all right? But the problem here is the clinical presentation. So this is a patient with hypothyroidism, right? This is a patient with hypothyroidism who's coming with shock, right? Coming with shock with elevated jugular venous pressure. So one, as you correctly guessed, one of the main conditions where you get elevated JVP edema with clear lungs is right heart failure. But the other condition is pericardial effusion or a cardiac tamponade. When you have a pericardial effusion or a cardiac tamponade, again, your lungs are quite clear, right? So in this context, in a patient with hypothyroidism, coming with this presentation, you have to think about pericardial effusion. Because patients with hypothyroidism, they can get pericardial effusion, and sometimes the pericardial effusion can become so big that it will prevent the heart from relaxing and contracting, and you can go into shock. So this characteristic triad where you have soft heart sounds, shock, and elevated jugular venous pressure is seen in cardiac tamponade. Unfortunately, they didn't tell us that there's soft heart sounds, but I'm sure if you auscultate this patient, there should be soft heart sounds. So remember, the take-home message in this question is the fact that when you have heart failure with clear lungs, think of right heart failure as well as cardiac tamponade, right? So this is what an X-ray looks in a patient with a cardiac tamponade. So you can see that there's cardiomegaly because this might be the heart. Surrounding it is all the fluid. So you can get a huge pericardial effusion, which is compressing the heart. This is congestive cardiac failure, again, where you have cardiomegaly. Now, when you compare these two X-rays, the one on the left and the one on the right, the one on the left is a cardiac tamponade, one on the right is a congestive cardiac failure. The main difference is the lung field. Now, in congestive cardiac failure, the lungs are very much congested. Lungs are very much congested. But when you get a cardiac tamponade, the lungs are quite clear. So remember, cardiomegaly with clear lungs or right heart failure with clear lungs, think of cardiac tamponade as well. Right heart failure is also a possibility, but cardiac tamponade is what is the most likely cause in this patient. So the answer is cardiac tamponade. All right. So if you have any questions, please do ask, right? You can unmute yourself or you can answer you can ask on the chat box. All right. So next one, we have a 79-year-old male who's active and enjoyed walking, presenting with palpitations. And he has had several similar episodes in the past few weeks as well. Examination, he's having a pulse rate which is irregular with a rate of 130. Blood pressure is 140/80. Clear lungs and normal heart sounds. Past history of hypertension and ischemic heart disease. And they have given you the answer, ECG revealed an atrial fibrillation. So you don't have to work that out. But no signs of ischemia. X-ray is normal. What is the next best drug to use? So you have a 79-year-old gentleman coming with atrial fibrillation with a tachycardia of 130. And they're asking you what is the next best drug to be used. All right. Any answers? Yeah. So you have to choose a single best answer, right? So I can see some have given multiple answers, which unfortunately is not possible for SBA, right? You have to choose just one answer. All right. So you are dealing with a patient with a fast atrial fibrillation. So when we have a patient with a fast atrial fibrillation, we have several entities that we have to look into. One is we have to treat the underlying etiology, right? So if the patient is having a thyrotoxicosis, treat that. If the patient is having atrial fibrillation due to mitral stenosis, you treat that. Second thing is stroke prophylaxis. Because when you have an atrial fibrillation, one of your major concerns or worries is the fact that the patient can get emboli because you have very uncoordinated atrial contractions. So when you have very uncoordinated atrial contractions, you can get thrombosis within the atria and those can embolize to your brain and cause stroke. So we prevent stroke in atrial fibrillation by giving anticoagulants like warfarin, right? Then the next one is you have to go for either rate control or rhythm control. Now, when we talk about rate control and rhythm control, rate control is when we slow down the heart. Rhythm control is when we make the heart rate regular. Because when you have a patient with atrial fibrillation, you have two problems. One is the heart rate is irregular, and the other one is the heart rate is fast. So rate control is to bring down the heart rate, but rhythm control is to make it regular. Now you can do both of that, right? You Rhythm control, you can do it using DC cardioversion, right? That is, you shock the patient. Or you can go for chemical cardioversion by using drugs like amiodarone. All right. Rate control, we go for rate control drugs like beta blockers, calcium channel blockers, or digoxin. Now, when you get a patient, you have to choose whether you are going to go for rate control or rhythm control. Now, rhythm control is good for young patients where you want the heart rate to become regular. But when it comes to older patients, what we prefer is rate control. So in this 79-year-old man with a fast AF, our main concern is rate control. So the answer amiodarone is wrong because amiodarone is for rhythm control. That is something we would prefer in younger patients. All right. So in this patient, we have to go for rate control. So what are we going to use? Are we going to go for ivermectin, digoxin, diltiazem, or metoprolol? So ivermectin is not used for the treatment of atrial fibrillation because ivermectin can be used only in a patient who has a normal conducting system, right? So if the patient has a normal conducting system, we can use ivermectin. Patients with atrial fibrillation have a pathological conducting system. So since they have a problem in the conducting system, we can't use ivermectin. So ivermectin is out. Then we have to choose between digoxin, diltiazem, and metoprolol. So in other words, we have to choose between digoxin, calcium channel blocker, or beta blocker. So when we have to go for a rate control, remember beta blocker is the drug of choice. Always beta blocker is the drug of choice. But there are certain patients where we can't use beta blockers. For example, patients with COPD or asthma. Because for those patients, if you go and give beta blockers, their asthma and COPD will get worse. For them, we can go for calcium channel blockers, right? Then if the patient is having heart failure, if the patient is having atrial fibrillation with overt heart failure, we can't use beta blockers or calcium channel blockers. Then we have to go for digoxin. All right. So when we go for the management of AF, first choose whether it's rate control or rhythm control. Older, less active patients, rate control. Younger patients, rhythm control. When it comes to rate control, if the patient is in heart failure, go for digoxin. Patient is not in heart failure, go for beta blockers. If beta blockers are contraindicated, go for calcium channel blockers. So here we have a 79-year-old man. So we are going to go for rate control. Is the patient in heart failure? No. So we can go for a beta blocker. Does the patient have contraindication for beta blockers? No. So the answer here should be a beta blocker. So answer we are going to choose is metoprolol. If this patient had COPD or asthma, then we can think of giving diltiazem. If this patient had features of heart failure, then we can think of giving digoxin. So that is how you approach and treat a patient with AF. All right. Any questions there? It's an important topic, AF. You should be very familiar with it. All right. So next question. All right. So 35-year-old female, newly diagnosed with asthma. She has day symptoms once a month without awakening in the night. What is the best initial management option? All right. Can you answer? This is an easy one. I think all of you should get this correct. So there is a question, is ivermectin the best choice when there's no fibrillation? Yeah, so ivermectin can be used only if you have a normal conducting system. So things like MI, myocardial infarction, where you want to slow down the heart rate, that is where you can use ivermectin. I won't say it's the best choice. So best choice is always a beta blocker. But if the beta blocker is not effective enough to control the heart rate, next step would be to add a ivermectin. All right. So I hope that answers your question. I can see a few answers between B and E. Yes, so again, this is a new concept that has come up, right? So this patient is having intermittent asthma, right? I think all of you must have diagnosed that. Patient is having infrequent episodes of asthma. So that is intermittent asthma. So when a patient is having intermittent asthma, we don't have to go for regular treatment, right? We have to go for treatment only when needed, right? So that is the main thing. But in this question, you don't need to even know that because all the stems say as needed, right? So, but remember when it's intermittent asthma, it's only as needed therapy. Now, when we talked about intermittent asthma in the past, the treatment used to be salbutamol as needed. So the answer used to be E in the past. Okay, but things have changed now. Because what they have seen is that when you use as needed salbutamol alone, so that is you are using salbutamol alone without giving a steroid. So if you are just giving salbutamol and not giving a steroid, the main problem is it can actually increase and worsen the exacerbations, and it can even worsen the mortality. So there have been some multiple trials that have come out, and they have shown that using salbutamol alone actually increases mortality and worsens prognosis. So because of that, in addition to a bronchodilator, in addition to giving an as needed bronchodilator, along with the bronchodilator, you have to go for steroid as well. So the answer that you have to choose is a as needed bronchodilator with a steroid. And the recommended bronchodilator and steroid is budesonide and formoterol. So the new guidelines, so you have something called the GINA guidelines for asthma. GINA guidelines, what they say is for intermittent asthma, go for as needed budesonide and formoterol. So the answer is B. If you have any questions, please ask. All right, 18th one. Again, an easy one. 62-year-old male with a history of smoking 40 pack years presented with dyspnea and is being investigated for COPD. Which of the following would indicate an alternative diagnosis? All right. Answers. So do you think chronic cough? So what they're saying is you have a smoker coming with shortness of breath and they're thinking it's COPD. But what are the things that will tell you that it's not COPD, but it's something else? So in other words, they're asking which of these 5 are not suggestive of COPD. Okay, I can see a few answers. Yeah. So chronic cough. Now, chronic cough is seen in COPD. No? So one of the cardinal features of COPD is cough, shortness of breath, and sputum production over a long period of time. All right. Episodic nocturnal wheeze. Now, what is the important differential for COPD? Asthma, right? So the main differential between asthma and COPD is the reversibility. Now, in both COPD and asthma, there is bronchoconstriction. So you have normal bronchi which carry air, right, to the lungs. In COPD and asthma, these bronchi are constricted. The difference is that in asthma, this constricted bronchi can dilate again. So it's episodic. Constricts, dilates, constricts, dilates. COPD is more of a more irreversible constriction. It doesn't tend to dilate. So COPD symptoms are more or less persistent. They are not episodic. Asthma, since they are constricting, dilating, you get episodic symptoms. And symptoms of asthma are particularly more commonly seen in the night and early morning. So episodic nocturnal wheeze is more suggestive of an asthma. Episodic nocturnal wheeze is against the diagnosis of COPD. Because in COPD, you should be having wheeze throughout the day. Throughout the day, you should be wheezing. If the wheezing is particularly in the night or early morning, that is more towards asthma. So episodic nocturnal wheeze is more towards asthma. Exertional dyspnea, yeah, COPD patients can have exertional dyspnea. Frequent episodes of bronchitis, absolutely true. You can get episodes of severe cough with sputum production. Regular sputum production, again true. So all of these symptoms are very characteristic of COPD, except the episodic nature, which is more in favor of asthma. So I hope that is clear. That is quite a straightforward one. All right, next one. 66-year-old male with 2-month history of chronic cough. Which of the following pairs of clinical features is suggestive of bronchial carcinoma? So they're asking from these clinical symptoms, what is more suggestive of lung cancer? All right, so any answers? Yes, so I can see some correct answers. So finger clubbing and bibasal crepitations. So finger clubbing and bibasal crepitations are seen in fibrotic lungs, right? So when you have lung fibrosis, idiopathic lung fibrosis, rheumatoid arthritis causing lung fibrosis, hypersensitive pneumonitis, you can get clubbing along with bibasal crepitations. So that is not a characteristic feature of lung malignancy. That is a characteristic feature of lung fibrosis. Cigarette smoking and bilateral bronchi, very characteristic of COPD. COPD patients have cigarette smoking, and when you auscultate, there's bilateral bronchi. Loss of weight and left lower lobe dullness. Left lower lobe dullness can be due to a mass. It can be due to consolidation also. It can be due to an effusion also, yes. But effusion, you get stony dullness. So left lower lobe dullness, think about a mass. Mass with loss of weight is malignancy until unless proven. So loss of weight and left lower lobe dullness is very much suggestive of lung cancer. So that is a correct answer. Pleuritic chest pain with the area of bronchial breathing. Bronchial breathing is due to consolidations like pneumonia. And in pneumonia, you characteristically get a pleuritic chest pain. So pleuritic chest pain and bronchial breathing, think about a pneumonia causing consolidation. Production of copious amount of sputum and clubbing. So fifth one, can someone tell me what that lung condition is? Copious amount of sputum and clubbing. Sorry? Yeah, very good. Bronchiectasis. So clubbing with copious amount of sputum production is usually seen in bronchiectasis, right? So all of you have chosen the correct answer, loss of weight with left lower lobe dullness. So I think that was pretty straightforward one. But figure out what the other conditions are causing as well, right? Finger clubbing and bibasic capitation, what other conditions? Because next time you might get what clinical feature is more suggestive of bronchiectasis. Then you have to choose clubbing and copious amount of sputum. All right. Okay, 20th one, bit of a long one and a bit of a difficult one. So don't worry, I'll help you with this. 56-year-old female coming with pruritus for 2 years. Other than that, she was asymptomatic. There was no past medical history, not on any routine drugs. Examination, there's xanthelasma and scratch marks were observed. The investigation findings were as follows. WBC 5.7, HB 13.8, sodium 138, potassium 4.2, creatinine 88, ALT 90, AST 80, IgM positive, ANA negative, serum bilirubin 48, which is elevated, ALP high 358, INR high 3, albumin is 18, cholesterol is high. On ultrasound, there's evidence of chronic liver cell disease. So I'll simplify this for you, right? So we have a 56-year-old female with CLCD, and they're asking us what is the cause of the pruritus or the CLCD, either, right? So when we talk about CLCD, it can be due to alcohol, right? It can be due to hepatitis B and C. It can be due to non-alcoholic fatty liver disease. It can be due to genetic causes like hemochromatosis, Wilson's disease. It can be due to primary sclerosing cholangitis, primary biliary cholangitis, or it can be due to things like drugs. All right. When we have cirrhosis with significant jaundice and pruritus, what is the differential diagnosis that you have to consider? So I'll put the answers up here for you. From these 5 conditions, think about the condition where you get significant pruritus. Yes, excellent. So remember from the causes of cirrhosis, in patients coming with cirrhosis, if you get significant pruritus, there are mainly 2 conditions, primary biliary cirrhosis and primary sclerosing cholangitis. Primary biliary cirrhosis usually occurs in middle-aged females, and they usually have a positive anti-mitochondrial antibody and positive IgM. Primary sclerosing cholangitis again comes with pruritus, but that is mostly seen in young males and patients who have ulcerative colitis. All right. So if this was a, let's say like a 30-year-old male with altered bowel habits and the same picture, then you have to think of primary sclerosing cholangitis. Since this is a middle-aged female coming with obstructive jaundice and cirrhosis with a positive IgM, sometimes they might give a positive anti-mitochondrial antibody. So if you have positive anti-mitochondrial antibody or positive IgM, then think about primary biliary cirrhosis, right? ANA will be positive in autoimmune hepatitis. So autoimmune hepatitis will have positive ANA. They will not usually come with pruritus. Hepatitis B and NASH will also not come with pruritus. Both D and E come with pruritus, but the clinical picture is more suggestive of primary biliary cirrhosis. So excellent. Most of you have chosen the correct answer. All right. Again, a pretty straightforward one. 33-year-old male coming with bloodstained diarrhea for 3 weeks, associated with weight loss of 2 kilos, and there's an anorectal fistula. Okay, my question, what is the diagnosis? I think all of you should be able to answer this one. What is the diagnosis? Young male, 3-week history of bloodstained diarrhea and weight loss, and now having an anorectal fistula. So what is your diagnosis? Yeah, diagnosis. What is this clinical condition? Young male with bloodstained diarrhea and weight loss.
Colorectal carcinoma.
Yeah, so colorectal carcinoma is a possibility. Only thing is the young age. No? So young age patients coming with bloodstained diarrhea, I agree. Colorectal carcinoma is a possibility because there's weight loss as well and there's a fistula also. But in a younger patient, what is another differential you can entertain other than colorectal cancer?
Ulcerative colitis.
Yeah, very good. So inflammatory bowel disease, ulcerative colitis or Crohn's disease. So bloodstained diarrhea, it's more favoring ulcerative colitis, but the anorectal fistula is more favoring Crohn's. Right? So one of the main things to exclude in this patient is inflammatory bowel disease, right? Inflammatory bowel disease, the bowel habits, the bloodstained diarrhea is suggestive of ulcerative colitis. Anorectal fistula, more suggestive of Crohn's. The only way to confirm is to do a what?
Colonoscopy.
Yeah, excellent. So you have to do a colonoscopy and take a biopsy, right? So when you do a colonoscopy, if it is ulcerative colitis, you will get something that looks like this. So you get a very inflamed bowel mucosa extending all the way from your anus upwards. So you get a proctitis colitis. So there's inflamed mucosa all the way from your anal canal up to the colon. If it is Crohn's disease, you get very patchy involvement. Some involvement of the terminal ileum, some involvement of the colon, like that very patchy involvement. Continuous involvement, ulcerative colitis. So the only way to know that is to look inside the bowel. So we have to do a colonoscopy. So when you do the colonoscopy, you will see inflamed mucosa. Then you will take a biopsy from the inflamed mucosa and you will observe under the microscope. Ulcerative colitis, you will get very superficial inflammation with crypt abscess formation, goblet cell depletion. In Crohn's disease, you get a very transmural inflammation with non-caseating granulomas. So the only way to come to a diagnosis is to do a colonoscopy and biopsy. All right, good. So next one. 65-year-old man with heavy consumption of alcohol is coming with confusion, imbalance, and a bilateral lateral rectus palsy. Investigations are listed below. So investigations, don't worry about the investigations. We just go by the history. 65-year-old man, heavy consumption of alcohol, now coming with confusion, imbalance, and a bilateral lateral rectus palsy. What is your diagnosis? First, tell me the diagnosis. Following alcohol,
It's a
confusion.
stroke.
Sorry?
Stroke.
Stroke. Yeah, so stroke is a possibility, fine. Anything else? Any way to sort of combine these symptoms with the alcohol? I mean, alcohol in the long run can produce stroke. I agree. But just because you suddenly take alcohol, you're not going to get a stroke. So with this sudden heavy consumption of alcohol, these symptoms, what do you think?
Alcohol poisoning?
Sorry?
Alcohol poisoning?
Yeah, so alcohol toxicity, right? Okay, alcohol toxicity. So alcohol toxicity typically produces imbalance and cerebellar signs. When you get the bilateral lateral, so I like the way you're thinking, right? So that's correct. But with the bilateral lateral rectus palsy, can you think of something else? Yeah. So with the bilateral lateral rectus palsy, you can also get a condition called Wernicke's encephalopathy, right? So I hope you've heard about this term before. So Wernicke's syndrome is a complication of alcohol, right? So when you take too much of alcohol, you can get this typical triad where you can get encephalopathy, right? You can get encephalopathy where you have disorientation, confusion, and you can get this oculomotor dysfunction. So you can get a lot of eye signs, nystagmus, lateral rectus palsy, and incoordination. So like you said, encephalopathy and ataxia can be seen in alcohol poisoning. So I like your answer. That's very good thinking. Encephalopathy, ataxia, typical symptoms of alcohol poisoning. This nystagmus lateral rectus palsy is what helps you to come to the diagnosis of Wernicke's syndrome. Because lateral rectus palsy is not very common with just alcohol intoxication. That is due to Wernicke's syndrome. All right. So remember, in a patient with significant alcohol intake, this triad of encephalopathy, eye symptoms, and ataxia, think of Wernicke's encephalopathy, and the treatment is to give thiamine. And the important thing is, most of these patients, including our patient, they tend to be hypoglycemic, right? They're hypoglycemic. They have low sugar. Here also the patient's RBS is 60. So what happens is when you suddenly, so they have thiamine deficiency, right? When you suddenly give them dextrose, that deficiency will get precipitated. So any patient with alcohol who is having features of Wernicke's, if you go and give them dextrose, the symptoms will suddenly get worse, right? So to prevent that from happening, we should always give thiamine and then give the dextrose. This is again a very, very common question. In fact, this was asked during my exam as well back in 2018. I can remember this SBA was asked. So patient, alcohol patient, coming with hypoglycemia, what is the next step? So when we look at the next step, our first impulse is to treat the hypoglycemia, right? That is to give dextrose. But that is dangerous in alcoholics because in alcoholics, if you give dextrose straight away, that can precipitate Wernicke's encephalopathy. So how do you prevent it? Give thiamine, then give the dextrose. So first step in the management is always thiamine followed by dextrose. So that is how you treat a Wernicke's encephalopathy. You treat with IV thiamine. All right. So the important take-home message: this triad, think of Wernicke's encephalopathy or Wernicke's syndrome. They can be hypoglycemic. Before you treat the hypoglycemia, make sure that you give thiamine and then treat the hypoglycemia. Established Wernicke's syndrome, treatment is to go for IV thiamine. All right. So any questions there? So that is again important clinical entity that you should be familiar with, right? Wernicke's encephalopathy. All right. Okay, 23. 27-year-old female with viral hepatitis in acute liver failure, coming with severe loss of appetite, persistent vomiting, pulse rate is 110, blood pressure is 80/60. Following investigations are available. She's having a high HB with high PCV, high INR, and normal creatinine. They're asking what is the best option to prevent acute kidney injury. So we are talking about a patient with acute liver failure due to viral hepatitis who is in shock, possibly dehydrated because the PCV is quite high. And they are asking us, how are we going to prevent acute kidney injury? So that's how are we going to prevent acute kidney injury? Are we going to repeatedly hydrate the patient? Are we going to go for dobutamine, plasmapheresis, fresh frozen plasma, or NEC? Yeah. So in this patient, all of these things can be done, right? You can give a NEC infusion in acute liver failure because there's some evidence that NEC will help to reduce the complications of liver failure by replacing glutathione. Patient is having a coagulopathy, so if the patient gets bleeding, we can go for fresh frozen plasma. Plasmapheresis is a bit of a doubtful thing. Some evidence is there that plasmapheresis can help with liver failure. But the main problem here is that the patient is in shock, right? Patient is in shock. Patient is having a BP of 80/60. Patient is in hypovolemic shock, probably due to the persistent vomiting. And patient is severely dehydrated. Patient's HB is high. For a 27-year-old female, HB of 16 is high. PCV of 58 is very high. Patient is definitely dehydrated. So the reason why this patient can get an acute kidney injury is due to dehydration, right? Dehydration is going to cause a pre-renal acute kidney injury. So the only way to treat this patient is to pump fluid. Patient is deficient in fluid. Patient's kidneys are starving of fluid. So it's going to go into acute kidney injury. So pump in fluid. So easy one. This patient who is severely dehydrated and in shock, the only way to prevent acute kidney injury is to go for repeated hydration with crystalloid boluses. Of course, even after repeated hydration, if the BP is not picking up, then you can think of giving inotropes like dobutamine, I agree. But the first step and the best step is to go for repeated hydration, right? So that way you can prevent the pre-renal AKI. Any doubts there? All right. So next one. So this is again a bit of a difficult one. So 26-year-old female with type 1 diabetes mellitus for 10 years is coming with one episode of painless hematuria. In the UFR, there's trace protein, field full red cells without dysmorphic RBCs. X-ray KUB was normal. Ultrasound shows large kidneys which were compatible with diabetic nephropathy. What is the most probable cause for the hematuria? Okay, so let's take, so can you give some answers? So all of these 5 answers can cause hematuria. Our concern is which is the answer for this question, right? Cystitis can cause hematuria, glomerulonephritis can cause, papillary necrosis can cause, renal cell carcinoma can cause, and renal calculi can cause. Yeah, good. So I can see the correct answer. So cystitis means inflammation of the bladder. So when you have inflammation of the bladder, you can get hematuria. But what is the cardinal thing about cystitis? Cystitis is very, very painful. When you have a cystitis, you get very severe lower abdominal pain with the hematuria. So this patient clearly has painless hematuria. So cystitis is a cause of painful hematuria. Glomerulonephritis, yes, it can cause hematuria. But glomerulonephritis, the red cells are coming from the glomeruli. It's not coming from the renal tract. So because they're coming from, so when you have hematuria is basically the presence of blood in urine, right? So when you have blood in urine, it can either be coming from the glomeruli or it can be coming from the renal tract. So the way we differentiate is by looking for dysmorphic RBCs. If we see dysmorphic RBCs, that means the red cells are coming from the glomeruli. It's squeezing through pathological glomeruli. So you are getting very abnormal dysmorphic RBCs. So if it's a glomerular pathology, patient should have dysmorphic RBCs. Since this patient is not having dysmorphic RBCs, glomerulonephritis is wrong. So that means this patient is having a pathology not involving the glomeruli, right? Let's skip C for once, for the time being. Renal cell carcinoma, painless hematuria, absolutely correct. No dysmorphic RBC, yes. But when you do an ultrasound KUB, you should see a lesion, right? So when you image the kidneys, you should see the cancer. So the fact that the ultrasound is not showing features of cancer, renal cell carcinoma is unlikely. Renal calculi, again, wrong, because renal calculi is painful hematuria. I mean, you must have studied that in surgery. Renal calculi causes very painful hematuria. And 90% of the renal calculi are seen in X-rays. but here the X-ray was known. So we are left with papillary necrosis. So the correct answer here is papillary necrosis. So papillary necrosis is a condition where your renal papilla get necrosed due to various conditions. So all these conditions can cause damage and necrosis of the renal papilla. And as a result, fragments of the renal papilla will come out in the urine. So what you get is very painless fragments of renal papilla coming out. So you're going to get hematuria, and you can even get clumps of tissues coming out with your urine. So renal papillary necrosis is an important cause of painless hematuria, and there are several conditions it is associated with. Easy mnemonic for you to remember the causes of renal papillary necrosis is postcards. So P is pyelonephritis, O is obstruction of the urogenital tract, S is sickle cell disease, T is tuberculosis, C is chronic liver cell disease, A is analgesia, R is renal transplant rejection, D is diabetes mellitus, and S is systemic vasculitis. So if you go back to our patient, the patient had type 1 diabetes mellitus for 10 years. So that is another clue that we are dealing with a renal papillary necrosis that is associated with diabetes mellitus. So remember, again, it's a bit of a rare disease, an underdiagnosed disease of hematuria. It causes painful hematuria. So memorize these causes, because if you know these causes, then you can link it and come to a diagnosis, right? So these are the main reasons why a patient can get renal papillary necrosis. All right, so we come to the last question of the day. You must be tired, so let's finish it off. 56-year-old patient with acute onset chest pain, diagnosed to have acute extensive anterior ST elevation myocardial infarction, and the patient has been thrombolized. Several hours later, he was found to have hypertension of 80/60, and he required inotrope support. Day 1, the creatinine is almost normal, 190. Day 2, in 24 hours, it has shot up to 411. So patient is having a rapid rise of creatinine. UFR protein plus, that is almost normal. Red blood cells nil, normal. Fast granular CAS. So what could be the reason for this presentation? All right, so last question, guys. Can I see some answers? All right, so a few more answers coming across. All right, so let's discuss these answers one by one. So bilateral renal artery stenosis. I mean, the clinical picture doesn't match, right? I mean, patient had a MI and then suddenly he has got a renal artery stenosis. So that doesn't really make sense, right? So renal artery stenosis, they can come with acute kidney injury. Particularly one possibility is that the patient might have been treated with an AC inhibitor. So when you have renal, because you can treat, when you treat myocardial infarction, one of the drugs that have prognostic benefit is AC inhibitors. But when you give AC inhibitors to a patient with renal artery stenosis, that can cause acute kidney injury. So that could be a possibility. Patient has been given AC inhibitors, and since they have bilateral renal artery stenosis, patient went into AKI. But if you have bilateral renal artery stenosis, your blood pressure is going to be very high. This patient is hypertensive. So renal artery stenosis patients won't come with low blood pressure. They will come with high blood pressure. Again, drug-induced interstitial nephritis. So yes, I agree with that answer as well. Some of you have chosen it because you can give several drugs in MI. Some patients might even receive NSAIDs as a part of the treatment by GPs. So these drugs can cause interstitial nephritis, and these drugs can cause an AKI. So that is a possible answer, I agree. Acute tubular necrosis, very much possible. Because when you have ischemia to your kidney, right? So when the blood supply to your kidney is low, your kidney starts becoming necrotic. Your tubules, your tissues start dying. So this patient has been hypotensive with 80/60. That means the patient's blood pressure has been quite low for almost 24 hours. So any patient who's having low blood pressure is going to get ischemia of the kidneys, and that can cause acute tubular necrosis. So that is a very possible answer. Renal vein thrombosis. Again, I agree, renal vein thrombosis can cause acute kidney injury, but the cardinal presentation of a renal vein thrombosis is with hematuria. So patients with renal vein thrombosis can present with hematuria. All right. So gross hematuria is the classical presentation of renal vein thrombosis. All right. These patients, the UFR, there is no red cells. If there's no red cells, renal vein thrombosis is unlikely. Glomerulonephritis, yes, it can produce acute kidney injury, but glomerulonephritis, again, the patient will come with hematuria. There should be red blood cells, and there should be red blood cell cast. So in the absence of red blood cells and in the absence of red blood cell cast, glomerulonephritis is again unlikely. So the two possible answers are drug-induced interstitial nephritis and acute tubular necrosis. But with the given clinical picture where the patient has been hypotensive for some time, the best answer is acute tubular necrosis. So guys, this is usually what happens in SBA. You will be left with two very close answers, and it's very difficult to sometimes choose. So you have to go through the question like part by part and try to find a clue to help you differentiate, right? So here the differentiating point is the shock, and that tells you that you are dealing with an acute tubular necrosis. Right, guys, so that comes to the end of today's session. Thank you for joining. So if you have any questions, please do ask. I know it's late. I'm sorry if I went beyond time. I had a few technical difficulties to start with, getting the sharing the screen and all that. Sorry about that. So if you have any questions, I'm more than happy to stay behind for a few more minutes and answer them. So if you have any questions, please go ahead and ask me. You can unmute yourself and ask me, or you can even drop a message on the chat. I mean, if you have any questions regarding the exam, please go ahead as well about studying, what methods to use, what sort of, how you're going to go about it, how you're going to plan your time. So I can help you with that as well. I've done this exam also in 2018, so I've had some experience as well. So I'll be more than happy to answer any questions. I know it's late, so if you do have questions but you're feeling sleepy, you can always drop us a message on our WhatsApp, and I will be able to answer them later as well. So thank you guys for joining, and I hope this was useful, and I hope you learned something.